denk dat je niet zo vreselijk veel macht hebt om dingen anders te laten gaan. Het gebeurt gewoon.
Maar ja, ik ben wel blij dat ik gewoon nog leef natuurlijk.
On voit l'être aimé, complètement distordu et il est là, il est plus là, mais en même temps il est là.
Quando hai alle spalle un dolore, una sofferenza del genere, apprezzi anche le piccole cose. Non è scontato niente, non è scontato che respiri, non è scontato che stai in piedi e cammini, puoi correre, non è scontato vedere il sole, non è scontato niente.
Bijna verdwaasd rond, in een trance rond. Maar ik moet zeggen, de zorg eromheen is wel heel erg goed. En ja, het was een heftige tijd, maar wel een mooie tijd.
Welke gevoelens ik heb ervaren. En je bent ontzettend nauw betrokken bij mijn vrouw, wat die meemaakt. En je kunt daar niks mee, maar je moet er zelf mee uit de voeten. En je hebt wel het volle vertrouwen, dat had ik wel steeds.
Io sono un medico di terapia intensiva, non un rianimatore, nel senso che lavoro con i neonati, quindi mi occupo di tutt'altra di bambini molto molto piccoli, non faccio il loro stesso lavoro, però chiaramente il rapporto con i medici è stato condizionato anche dalla mia posizione. Tra l'altro sono dei colleghi perché sono nel mio stesso, quindi da una parte ero sicuramente facilitata nel comprendere razionalmente quello che stava succedendo, cioè non avevo bisogno dei lunghissimi colloqui perché mi spiegassero, per avere notizie cliniche, perché era più semplice riassumermi le cose. D'altra parte, dal punto di vista umano, dal punto di vista emotivo, questo non è servito a niente, anzi forse ha peggiorato le cose, perché sapevo cosa poteva sucedere e non volevo accettarlo.
Ahora lo que me motiva es mejorar la vida de la gente. Ya no es tanto la técnica, ¿no?, como cuando eres joven, porque llega un punto que la técnica es técnica y no tiene ningún secreto, sino las pequeñas cosas que pueden hacer que marcan la diferencia. El hablar con el paciente, con la familia, el hacer una educación sanitaria que nadie ha hecho hasta ese punto y tú no lo sabías porque dabas por hecho que lo habían hecho. Esas cosas son las que te motivan, el mejorar el cuidado del paciente.
Il faut faire du cas par cas, en fait. C'est primordial, parce que chaque histoire est différente. Et quand vous vous trouvez en tant que patient, en tant que famille de patients, dans cette situation, dans un univers où vous ne parlez pas cette langue-là, cette langue faite d'acronymes et de termes techniques que vous ne connaissez pas, quand vous vous retrouvez face au savoir et que du coup vous vous retrouvez impuissant, que vous vous retrouvez stupide, que vous vous retrouvez humilié, que vous vous retrouvez démuni, comment faire?
Jokainen lääkäri varmaan pelkää komplikaatiota tai jotakin, että mitään ei hiffaa jotain juttua, mitä olisi pitänyt hiffata, joskin siinäkin auttaa se, että harvoin tekee yksin koko päivä töitä. Nämä tuli nyt äkkiseltään mulle mieleen.
And what scares me is that making those decisions and making those wrong decisions and the realization that that decision in 3-4 weeks' time, where you end up having a patient who, in effect, can be crippled by life-sustaining therapy, which may not have been in their best interests or the family's best interests. And that still scares me. And I think it scares a lot of colleagues, but intensive care is much more multidisciplinary now, and I think that has helped our decision-making and has reduced that fear factor.
Honesty and humility go a long way. And most patients and relatives understand that we're also human and mistakes can happen and should be openly discussed.
Οι ασθενείς όμως έρχονται σε επαφή με εμάς, ιδιαίτερα αυτοί που βγαίνουν από το νοσοκομείο, πηγαίνουν σε κέντρα αποκατάστασης και ύστερα από πάρα πολύ καιρό έρχονται να μας συναντήσουν, γιατί ξέρουν τα πρόσωπά μας, τις φωνές μας, τον αγώνα που δίνουμε μέσα στο χώρο για να καταφέρουμε να τους σώσουμε, να επιβιώσουν και έρχονται να μας δουν, να μας γνωρίσουν από κοντά, να τους δούμε κι εμείς.
Together with my colleagues, in particular the nursing colleagues, we arranged a wedding for a patient who was at the end of his life and had decided to marry his long-term partner before he later died. And it was very moving to be part of this very special event in the intensive care unit.
It's a real privilege to be able to support a patient and their family through that, what I hope is the worst thing that ever happens to them in their lives, to be able to support them through that, hopefully to recovery, or to support them through managing a dignified death.
Il faut ramener la vie. Pourquoi est-ce que tout est si blanc et voire gris? Pourquoi est-ce que ce lino couine autant sous les crocs des médecins? C'est insoutenable. Pourquoi est-ce que tout est autant aseptisé? C'est pas 3 photos qui vont empêcher les gens de travailler. Moi, je pense que c'est important de ramener de la vie à cet endroit où on se trouve à la frontière au bord d'eux, on se trouve dans une espèce de no man's land où on sait pas sur quoi ça va déboucher, quoi.
La mia opinione della terapia intensiva è fantastica perché mi hanno salvato la vita e dopo 3 anni sono qui. Anche a un altro ospedale che mi hanno dato per morto, per fortuna sono arrivato a questa terapia intensiva e mi hanno salvato veramente la vita.
Solo belle cose possono uscire dalla mia bocca, ovviamente, perché senza di loro non sarei qui, ripeto, non sarei qui oggi.
Intensive care medicine allows me to learn something new every day. So every day I meet colleagues and I hear of their new technologies, new advances, and progress in their particular specialty. But most importantly, every day is a different day with new challenges, and I enjoy the interaction with my colleagues and most importantly with patients and their relatives. So it provides a great variety, it's different every day, and it's a specialty where progress is made on a regular basis.
Grazie perché mi hanno ricordato anche come si lavora. Cioè, io faccio questo mestiere, lo faccio da tanti anni, ci sono dei momenti in cui sei stanco, in cui hai le tue cose, nel senso che hai la tua vita, hai delle preoccupazioni, però io ero serena quando andavo via, non perché sapevo che non sarebbe morto, poteva morire, poteva star male, ma era nelle mani migliori. Sapevo che era nelle migliori mani e questo mi dava quel minimo di tranquillità che potevo cercare. È giusto che i bambini che mi vengono affidati e i genitori quando vanno a casa possono pensare la stessa cosa. Siamo nelle migliori mani, quindi dobbiamo sempre fare il meglio. Grazie a loro per esserlo il meglio.
I'm an intensive care nurse, and I'm proud to work with a multidisciplinary team to work together to fight COVID-19. Together we are intensive care medicine.
I'm an anaesthetist, and I'm proud to be an intensivist. We intensivists are working together to fight COVID-19. Together we are intensive care medicine.
I'm a primary intensivist, and I'm proud of it. We intensivists are working together side by side to fight COVID-19. Together, we are intensive care medicine.
I am an anesthesiologist, and I'm proud to be an intensivist. We intensivists working together to fight the COVID-19. Together, we are intensive care medicine.
I am a surgeon, and I'm proud to be an intensivist as well. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.
Good afternoon, ladies and gentlemen, and thank you for joining again this special European Society of Intensive Care Medicine and a live webinar to address the management of COVID-19 in low and middle income countries. COVID-19 has had an economic and health impact on 227 countries, areas, and territories throughout the world. While countries in Europe are beginning to see light at the end of the tunnel, and reductions in the number of confirmed cases, and are now easing some of their restrictions, different patterns are emerging in low-income settings where capacity is lowest. 85% of the world's population live in low and middle-income countries. Cases have been confirmed in all African and South American countries. Africa is already overwhelmed by many ongoing disease outbreaks, and health resiliency is being severely tested. Early detection is therefore vital, and public health measures to suppress transmission must be rapid and decisive. Collective action is needed if we are to save potentially millions of lives. Today's webinar brings together leading experts from Europe, South Africa, Uganda, and Brazil, who will be sharing their clinical experience, and we are again honored to be joined by a representative of the World Health Organization Health Emergency Program, Infection Prevention and Control, Dr. April Beller. Before we begin the discussions, I will briefly introduce myself. I am Joseph Kesicioğlu, Head of Department of Intensive Care Medicine at the University Medical Center Utrecht, the Netherlands, and President of European Society of Intensive Care Medicine. I would also like to introduce Professor Massimo Antonelli, past President of European Society of Intensive Care Medicine, who was instrumental in the establishment of the Society's Fund Alive to provide educational activities for low and middle income countries. Massimo Antonelli is a professor of intensive care and anesthesiology at the Università Cattolica del Sacro Cuore, Rome, Italy, since 1999, and he is director of the Department of Anesthesiology and Intensive Care and Emergency Medicine of the Fondazione Policlinico Universitario Gemelli, Rome. Massimo Antonelli is former editor-in-chief of Intensive Care Medicine from 2007 to 2013, past president of the Italian Society of Anesthesiology and Intensive Care Medicine between 2013 and 2016, He served as president of our society from 2016 to 2018. Massimo will now explain in more detail the goals and achievements of Alive Fund.
Thank you very much, Joseph. I want just to add some other things to the nice introduction that Joseph has just made. What is the Alive? Alive is the ESICM Fund, and it is supported by the Kim Bodwin Foundation, and it was created in 2017 to promote patient care across the globe, create international cooperation and research, transfer knowledge, education and training that will contribute, for this is our aims and intention, to the improvement of the conditions of outcomes of critically ill patients in low and middle income countries. We intended to do that as a society supporting the fund, just implementing the training and the teaching doctors and ICU staff, the transfer of knowledge, and even donating medical advices and devices and equipment to the ICU, supporting patients and families, developing together clinical project research, and consequently try to improve the healthcare and welfare and the condition of our patients and quality of life. But together contributing with the colleagues coming from these low and middle income countries to the social, scientific, and cultural innovation in this country. The education and training initiative have been focused on the prevention and management of sepsis at the beginning and global infection in this area of the world. But why have we chosen sepsis? Sepsis is one of the major and the leading cause of death in the world. There are globally something like 30 million of cases per year, with having estimated death ranging between 6 and 9 million related to sepsis. And we have to remember that something like 60–80% of these deaths are indeed children living in low and middle income countries. That is why in a coordination with Professor Melvin Mayer, who is the chair of the ESICM Global Intensive Care Group, has been created a unique course that is being articulated over the last months, starting from June 2019 up to March 2020, immediately before the surge of the pandemic, in a course that hosted several delegates and consisting in 2 days sepsis training, in addition to bedside teaching, having an international and local faculty. And promoting this principle, we wanted to help as much as we could various countries, and despite they belong to different parts of the different regions of the world, the problem that they had to face concerning sepsis, and consequently nowadays concerning the big surge we are having and we are seeing all over the world with the COVID-19, a potential help in practice and in education. But I want to make just a small step backward, just to better illustrate the situation and what we are speaking about. The European Society of Intensive Care Medicine and the WHO launched in 2006 an initiative concerning the newborn sepsis and maternal sepsis, having a meeting and developing a program. Well, if you look at this slide, I want to draw your attention for a while. This is an analysis that concerns a specific area of the world, which is the Malawi. This slide, as you can see, has a number of different locations, and there you can see circles and squares with different colors, from the light blue up to the dark blue. This represents the possibility and the access to the key resources of implementing surviving sepsis recommendation in these areas. and regards very essential things such as the fluids, the antibiotics, the basic monitoring and infrastructure. And if you look at the location of the various colors, you may immediately realize that there are parts where these key resources are totally lacking and may be below, to some extent, the 10% of the possibility to accomplish the Surviving Sepsis campaign recommendation. And this is the context when we are speaking about the low and middle income countries where things may happen and can hit very hardly. Consider that in this area, we may have also the water supply far away from the remote villages, and these create difficult problems for the essential hygiene. And when we have a surge like this is the COVID-19, these numbers are all of you very well known. More than 7 million of confirmed cases and almost 500,000 deaths. But the fundamental problem was the rapid surge in all different countries with an exponential increase of the cases that created another impact and consequently a problem concerning the sustainability of all the healthcare system. This is just to illustrate you what I mean. In a pre-COVID era, the distribution in the Western countries, we are speaking about Europe, of the ICU beds was totally uneven. And there were countries like mine where the number of ICU beds were almost 13 beds per 100,000 people, inhabitants, and the Germany where this number was 3 times more, or UK, where is exactly half of what we had. You understand easily that as soon as you have a big surge, a dramatic impact, the only possibility that we had, and this is something that should be taken into consideration when you have in such short period of time a huge number of patients, the conversion of hospital structures to rapidly expand the ICU bed that were available. But on top of that, and after me, there will be a number of presentations focused into detail on the patients and therapies. But you have to consider that in case of COVID-19, we do have difficult patients, very hypoxemic, but despite that at time, not dyspnoic or not tachypneic, with bilateral interstitial infiltrates, with the classic ground glass, and often having the compliance measured after the intubation, which is almost normal at the beginning, but with a deep and important VAQ mismatch, with high D-dimers, ferritin or ADH, just to give you an idea. And we have to apply treatment in different contexts at the same time. Because when you have the total full occupancy of the ICU beds, you have to find out an alternative also outside, just setting up temporary ICU beds, and where you have to assist these patients also with high flow oxygen therapy or non-invasive ventilation. And when you have to intubate them, keep in mind that are complicated patients, you may be obliged to prone them several times before having an improvement. We had the advantage and disadvantage of starting first. In the very north region of Lombardy in Italy, there was the first hit of the COVID-19 and in Europe. And we reported the results in the data concerning the first 1,500 patients, and where we could show that despite this difficult situation, the mortality rate of this patient was contained, was just border within 26%. And looking at the distribution of age in the upper part of the slide, you can see that as it happened in many other parts of the world, the majority of patients were old patients, often with comorbidities, and having the most frequent access to the ICU in the range of their age between 60 and 90. And in most of them, there was a prompt application of invasive ventilation with the use of PEEP ranging between 12 and 14, and always having the majority of these patients with PF ratio on admission at the ICU around 150, 170, or even less. And if you look at the mortality rate, you can see that the last three columns are the most represented, and the mortality rate was the highest in the ages between 71 and 80 years of these patients. But the real matter is that, unfortunately, up to now, no therapies have been shown to effective. And has been tried several therapies from the various antivirals, all of them with contradictory and controversial results, steroids, inhibitors of cytokines like IL-6 monoclonal antibody, and so on. But none of them had indeed a real effective and certain effect. Even the plasma from recovering patients. And we do not have the vaccine. We are still waiting for that. So despite the fact that the therapy and the therapies are not so established and constant all over the world, and depending a lot on the knowledge and the changing of the knowledge over time during these few months, nonetheless, we learn a little bit to treat this patient in a better way with respect to the very beginning and saving more life. However, just to conclude and to explain why the LMIC Fund supports all the different initiatives against pandemia, there are very few and essential points. COVID-19, as our president said before, is the worst health crisis of our times. Many countries, including the low and middle income countries, are facing a strong excess demand for healthcare. Indeed, there are a number of critical patients, and not only the patients with COVID-19, there are also the other normal ICU patients with too few ICU beds and ventilators. This was one of the things that, at least in Europe, in various countries, was one of the major problems, step by step solved in various ways. But still, this one, like the protective devices for the personnel, remained at the very beginning a crucial point. But on top of that, we do not have, wherever you are, not enough medical and nursing personnel. So we have to find out a way. And one of the strategies was the strong collaboration with other colleagues coming from other specialties in a sort of multidisciplinary collaboration and training done on site or in the battlefield, let's say, together with the intensivist in order to get the best possible collaboration. And this is the strategy, the best strategy to win our war. All together, all intensivists, and supported the LMIC Fund. Thank you.
Thank you very much, Massimo, also for accepting to speak here as the real architect of the LMIC Fund. Now I would like to introduce my co-chair, Professor Mervyn Mer, who will be acting as one of our moderators throughout the afternoon. Professor Mer currently presides as a principal specialist at the Charlotte Maxeke Johannesburg Academic Hospital, Faculty of Health Sciences, University of the Witwatersrand, Johannesburg, South Africa. He also serves as clinical head of the Adult Multidisciplinary Intensive Care Unit at CMJAH. Professor Mer is involved in various aspects of clinical research and postgraduate and undergraduate teaching, and serves as an examiner for the College of Medicine of South Africa in several disciplines. He is the past president of the Critical Care Society of Southern Africa and is the current chairperson of the Global Intensive Care Working Group of European Society of Intensive Care Medicine. He's an invited member of the Society of Critical Care Medicine and European Society of Intensive Care Medicine venture that is currently addressing sepsis in developing countries. And in 2018, he was invited to become a panel member of the International Surviving Sepsis Campaign Guidelines. He also serves as a council member of the recently formed African Sepsis Alliance. Erwin, would you please invite the first speaker?
Thank you so very much, Joseph, and for the wonderful introduction. And it's indeed an absolute pleasure to be part of this webinar and part of this team. The first speaker to kick off with a definitive issue and relating to the topic COVID-19, what do we know about the disease, is Professor Armand Mekonso de Sup. Armand is currently head of critical care at the Henri Mondor Hospital in Paris, France, and in fact grew up in a resource-limited setting in Cameroon and subsequently did his medical training in France, where he obtained specialist qualifications in cardiology and critical care medicine. He currently is the director of CARMAS, which is the Cardiovascular and Respiratory Manifestations of ARDS and Sepsis Research Group, and his research interests include non-invasive hemodynamics, particularly echocardiography, ARDS, sepsis, weaning from mechanical ventilation, and sickle cell disease. I've had the pleasure of, in fact, sharing in some of the Alive projects with Armand. In fact, the initial one in Uganda we were together with, and not only is he a fabulous educator, a fabulous person, he's a fabulous speaker, as we're going to, I'm sure, see in the next couple of minutes. So, Armand, a real and absolute pleasure to number one, see you again after many months, and to welcome you to present a talk on what we currently know about this new disease. Thank you.
Thank you very much, Mervyn, for your kind words. So in 15 minutes, I'm going to try to share with you some elements of the pathophysiology, organ dysfunction, and causes of death from the COVID-19. So obviously, it's impossible to look at all the aspects of the disease, but we are going to try focusing on some points that may be important, especially in low and middle income countries. The first information is to state that despite the fact that COVID-19 is primarily a disease of the lung, you can see on this slide that many patients are presenting with acute respiratory distress syndrome. The most severe patients will also have other organ failures, and many of them multiple organ failures, the most frequent being a hemodynamic disorder with shock and acute kidney injury. And in the first reports, there was already mention of something going on concerning the coagulation. It was named disseminated intravascular coagulation, although it may not be exactly that, and also rhabdomyolysis. The prognosis of those organ dysfunctions is severe. You can see here in the Wuhan cohort that the survival probability at 28 days was rather low, near to 50%. And in many countries, this is the overall mortality in the most severe patient, especially if you take into account those who were not able to reach the ICU because of the limited places in the ICU. The first mechanism to look at is the mechanism of lung injury. And one of the most important questions about that is whether COVID-19 is a classical ARDS, or is it something specific, a little bit different? One of the authors who looked at this question very scrupulously is Luciano Gattinoni, stating that because many COVID-19 patients have a relatively preserved compliance of the respiratory system, but a profound hypoxemia, COVID-19 may not be a classical ARDS. And you can see on this picture, for example, that despite compliance above 50 milliliters per centimeters water, many patients can have an important shunt. So he proposed the concept of two phenotypes during COVID-19, a L phenotype characterized by very little condensations in the lung, as you can see here in the upper part in panel A, only ground glass densities with a relatively normal compliance, a low lung weight, and a low recruitability. And in these patients, the mechanism of hypoxemia is not still very clear. One hypothesis may be that they lost the regulation, especially hypoxic vasoconstriction. We will see some elements concerning the vasculitis later on that may go into that direction in terms of hypothesis. He also described type H that you can see here on the B panel, more close to what we all know in terms of ARDS, with dorsal condensations, decreased compliance. And he proposed that in this situation, there is some collapsed lung to recruit and higher levels of PEEP may be tried. Up to date, the proposal of two phenotypes in COVID-19 is not fully validated, but it is clear that the physiological presentation of these patients is not uniform. So it's important, especially in terms of PEEP, to try individualize the therapy. The second aspect, which is largely involved in the pathology, is the vascular disease. The portal of entry of the virus is ACE2, and this receptor is expressed by pneumocytes, but also on endothelial cells. And it is not very clear whether it is fully downregulated, upregulated or not, but it has the potential of causing dysregulated inflammation and causing endothelial dysfunction. And there have been many reports in the literature suggesting some vasculitis with inflammation of endothelial cells during this disease that may be the cause of in situ thrombosis and coagulopathy in these patients. The clinical correlate of that is the high prevalence of thrombotic events. In this study, for example, you see that up to 40% of ICU patients with COVID-19 exhibited a thrombotic event, with a large proportion, half of them, having pulmonary embolism. There are other studies going into the same direction. And in this study, for example, also in France, by Helms and co-authors, the prevalence of thrombotic disease was higher in COVID ARDS as compared to non-COVID ARDS. And you can see a 17% prevalence of pulmonary embolism, which is relatively high. Some authors proposed to use the D-dimers in order to detect patients which are at higher risk of pulmonary embolism during COVID-19. In this study, for example, you can see that the patients having D-dimers more than 5,000, here in blue and green, are more prone to have pulmonary embolism as compared to their counterparts. And using a cutoff value of 2,660 micrograms per liter, they were able to have a pretty good sensitivity at 100% in order to select patients that may undergo a CT angiography. The last study I want to show you concerning the vascular aspect of the disease is this one, published in the New England recently, highlighting the fact that there is some microthrombosis process within the lung, which is really important and very close to what was described in the early description of classical ARDS. But the new information in this study is that there is neoangiogenesis, which is specific to the COVID-19. And this may explain some loss of regulation of the pulmonary vasculature that may be the cause of profound hypoxemia despite preserved respiratory system compliance. So you see that patients with COVID-19 may have vascular involvement leading to cardiovascular failure, but the mechanisms of these failures can be very specific and different from one patient to another. For example, in the pediatric population, there have been a lot of reports concerning the inflammatory multisystem syndrome and the Kawasaki disease due to SARS-CoV-2. You can see that this is a disease affecting infants, especially those below the age of 15. But in the adult, there have also been reports of direct involvement of the heart with myocarditis that may be the central cause of cardiovascular failure. But other causes may be only the vasoplasia because we are facing an infection with signs of sepsis. Patients may also have obstruction of the pulmonary circulation. We have seen that there is a lot of microvascular thrombosis and also macrovascular thrombosis. And we also need to remember that many of these patients have comorbidities, including hypertension, diabetes, so they may have a baseline alteration of the heart with a baseline structural disease of the heart. So the only way to really scrutinize the mechanism of cardiovascular failure is to have an efficient bedside examination, and I think that echocardiography is probably the best tool to use in this situation. The kidney is also involved in the severe cases of COVID-19. The prevalence of acute kidney injury is high. You can see in this recent study that 80% of patients admitted in the ICU with COVID-19 had acute kidney injury. There is still a lot of debate concerning the mechanism of that kidney injury, but it's probably polymorph. This study proposed that it was a Fanconi-like process with a lot of involvement of tubular proximal cells, especially in patients having acute kidney injury in the intensive care unit. The proteinuria to creatinuria ratio is elevated in these patients. There have been reports of glomerular involvement. And because many patients have shock, it is also conceivable to think that there is a certain degree of acute tubular necrosis due to shock and or to the toxicity of the lot of medications we give them. The neurological failure is also present, and one of the most complete reports about it is this study published in the New England from a French group. They described a neurological failure due to sedation, because many of these patients have severe ARDS and may require massive doses of sedative. But they also observed a lot of agitation, 69%, of delirium, 65%, corticospinal tract signs, dysexecutive syndrome. When they did brain MRI to these patients, there was a leptomeningeal enhancement, perfusion abnormalities, some cerebral ischemic stroke, and they had some oligoclonal bands in the CSF analysis. They were not able to get some virus from the CSF. All RT-PCR were negative. So to date, there is no clear demonstration of a direct encephalitis due to the virus, but there is a huge neurological involvement due probably to the sepsis and to the medications used in these patients. On top of this central neurological involvement, there is a peripheral one, and we are all taking care of these patients now during the weaning phase in Europe, and we see that the incidence of ICU myopathy is high, although the reversal of this disease in these patients may be favorable. The immune system is heavily impacted by the COVID-19. The first picture is that of excessive reaction. We all see that those patients with a long-lasting fever of many days, even when they don't have super infection. There have been many reports of increased cytokines, especially IL-6. It is not clear to date whether they have higher levels of IL-6 as compared to classical ARDS or classical sepsis. But the most severe forms of COVID-19 tend to have more pro-inflammatory cytokines than the less severe forms. And the paradox is that despite this excessive innate immunity reaction, the adaptive immunity seems to be decreased with a classical lymphopenia. You can see here the counts of T lymphocytes, which are decreased in the severe forms as compared to those having a mild form. And if you go down to the subphenotype CD4, for example, there's also a depression of that adaptive immunity. It is not very clear whether this depression of immunity is the cause of the high incidence of ventilator-associated pneumonia, for example, or if it is only the duration of ventilation that is related to that. Many investigations are still needed to understand all the implications of immunity in this context. To finish, if we look at the causes of death during COVID-19, most patients will have a report of multi-organ failure death during the ICU stay. But there are some autopsy studies that get some important information. The first one is that in these patients dying of COVID-19, there are many associated comorbidities that may have been implicated in favoring the death. The majority of deaths are, however, directly related to COVID-19. And in this study, the authors wanted to emphasize the fact that pulmonary artery embolism was very frequent in the series, and 40% of patients died with a deep vein thrombosis. So this is probably an important information, especially in low and middle income countries, because the preventive implications of those deaths are achievable. Another study who looked at autopsy findings in this population also stressed the fact that a majority of patients, here 58%, had a deep venous thrombosis, and pulmonary embolism was considered as the direct cause of death in 4 patients. In the lung, they found diffuse alveolar damage, and they also found SARS-CoV-2 RNA, which is logical due to the pathophysiology of the disease. So the take-home messages are the following. COVID-19 is obviously a prominent respiratory disease, but the presentation in terms of physiology can be spatial with preserved compliance, leading to the hypothesis of non-purely respiratory hypoxemia. The involvement of the vasculature is important, probably because the portal of entry of the virus is H2, which is widely expressed on the vessels. And this is probably the reason why there is a lot of inflammation in the endothelium and in situ thrombosis, and also macrothrombosis, especially in the pulmonary vasculature. And the disease will involve almost all organs, with a particular attention to be paid to the kidney and to the immune system. Thank you for your attention.
Thanks very much, Armand, for an excellent overview and for a great introduction. There are some questions from the viewing audience, which we'll come to, but perhaps let's kick off with 1 or 2 simplistic elements right at the outset. One of the things that we've noted with this disease is that males tend to be predominantly affected. And chatting about the pathogenesis and so on, do you have an explanation for that?
No, the explanation is not clear. One possibility is that males are more exposed to the comorbidities that are related to the severe forms, especially hypertension, diabetes. There have also been hypotheses around the hormones because the ACE2 receptor can interact with sexual hormones, but I've not seen a paper giving a definite answer about that. So, for my opinion, it is probably related to the comorbidities that are more expressed by males.
Talking about that and talking about comorbidities and hypertension, and you alluded to the fact that ACE2 receptors are highly relevant in the pathogenetic process. What is your advice for patients who have comorbidities who are on ACE inhibitors? In many resource-limited countries, as you know, hypertension is absolutely endemic, often starting at a very, very young age. Many of the patients on ACE inhibitors. What would your advice be?
I'm in trouble with that question because you know that one of the main papers related to that question was recently retracted from the New England. So my position will be to follow the official position of the scientific societies of cardiologists, who based on the global literature suggested that we may not we may continue the medications of patients if they don't have another contraindication, a specific one, for those medications. When you look at the interaction of the receptor, it is really hard to be sure that the ACE inhibitors may be unfavorable. So my position will be to follow the recommendation and continue them. But in the ICU, we didn't have that question because many of our patients were hypotensive. So we had to stop all hypotensive medications.
Perfect. Certainly, as far as I'm aware, the ESC have put out a statement suggesting don't fiddle with the medication, just continue. And so that is the current scenario. Before I hand over to Joseph, a question from one of our viewers. In the setting of multiple organ dysfunction, when many organs are involved, how do you triage and what should you be addressing initially?
Obviously the lung, because if there was one organ to preserve from worsening, failure, that will be the lung, because our experience is that once the patients are intubated, the duration of intubation of mechanical ventilation is often very long. So in the context of low and middle income countries, preventing intubation would be the priority number one, and there will be a talk about the non-invasive techniques that can be used for that. And my second target would be the kidney, because there is a scarcity of extrarenal aspiration in low and middle income countries. So if I can avoid anuria, that will be a big achievement in these patients.
Joseph, I know there are some questions that have come through from some of the audience. I'm not sure if you have access to them. Would you like to go ahead and review some of those? I do have several others before we close this and move to the next topic, but I would hand over to Joseph, and if there are still 1 or 2 moments remaining, we could perhaps pose 1 or 2 further questions to Armand.
I think we can have a very short question because the time is running up. What is the role of the lung ultrasound in showing the differences between the 2 phenotypes of ARDS is one of the questions. Maybe you can give a short answer, Armand.
Yes, there have been interesting studies about that, but the problem here will be the clinical implication of phenotyping type H versus type L. So the main implication is how to set PEEP. So we may directly use lung ultrasound to set PEEP.
Okay. Well, thank you very much, Armand, for this nice talk. And I would like now to move to the next speaker, Martin Dünser. Martin is Vice Director of the Department of Anesthesiology and Intensive Care Medicine of the Kepler University Hospital and the Johannes Kepler University in Linz, in Austria. He was trained in anesthesia, intensive care, and emergency medicine, and he has worked as an intensive care consultant in Bern, Salzburg, and London. He is a pre-hospital emergency physician for the Austrian Red Cross and also worked in this role for London's air ambulance. In addition to his clinical work, Martin is interested in medical work in low and middle income countries and has been involved in field work in Africa and Asia. Martin serves as co-chair of the Sepsis in Resort Limited Nations initiative of the Surviving Sepsis campaign. He was co-founder and former chair of the European Society of Intensive Care Medicine Global Intensive Care Working Group, a former chair of the Trauma and Emergency Medicine section, and a past member of the Research and Congress Committees of European Society of Intensive Care Medicine. Martin's presentation will cover differentials, including the clinical signs, lab results, X-ray and sonography patterns, and testing. Martin,
Thank you very much, Joseph, for the introduction. I would like to speak on our experience we collected here in Austria during the wave of COVID-19 patients, which we saw from early March until mid to end April. And I would like to give you a very pragmatic, practical talk. So just to add on what Armand has so excellently presented for the pathophysiology. So I would like to start with the first problem we faced. So we had the issue of screening versus diagnosing. So for screening, which we used at the hospital entrance, we still currently screen, and we screen for the presence of those 6 symptoms you see here, including cough, sore throat, shortness of breath, fever, loss of taste or smell, and as a strong predictor, contact to a COVID-19 patient or the patient him or herself being in quarantine. However, screening has a high sensitivity but quite a low specificity. So that means that's good to separate those patients who might have COVID from other patients who don't have any of those symptoms. But if you want to go for diagnosing those patients, you need to go into much more detail and use another approach. So if you look at the international recommendations, how do we diagnose COVID-19? There are possible, probable, and confirmed cases. And at the end, it's only the laboratory which can tell you whether the patient has COVID-19 or not, or which confirms that the patient has COVID-19 or not. If you have a clinical suspicion, it's a possible case. If you have additional diagnostic suspicion, it's a probable case. But in the end, it's testing which will confirm the case. About testing, also we in Austria struggled, especially in the early days of the epidemic, because it's mainly or more or less only a molecular biological method of the reverse transcriptase PCR. It is a method which also currently is not widely available as a point of care test. So turnaround times of 3 to 4 hours, and over the weekends and at night times up to 24 hours were also common at our place. So this is a specific challenge for caring for those patients who are at times severely sick. One thing which we soon realized, and I would like to draw your attention to the above graph, is that some patients really, really look like having COVID-19, but their test results comes back negative. It seems that these data, this study here showed that especially after or before day 5 and after day 14, after day 10, the incidence of false negative PCR results, which were taken from nasopharyngeal swabs, increase. So we were lucky that most patients presented to the hospital after a couple of days of symptoms, and this was still the time window when the rate of false negative results was fairly low. But for especially as we know that the accessibility of healthcare systems in low and middle income countries is reduced and impaired, I think this is something which is important to keep in mind, that some patients present with the clinical and radiological appearance but have negative results. And in this case, always think of a false negative result. What did we do in those cases? We went for bronchoalveolar lavages and tried to confirm the virus there, which was occasionally the case in patients with a high clinical suspicion. But let me go back to the topic of the talk, which is how do you recognize those patients? And I would like first to focus on the clinical picture. You see a chameleon here. The problem with SARS-CoV-2 infection is it has a range from asymptomatic spreaders, which are notoriously almost impossible to identify clinically. And these are usually patients coming for another reason to the hospital, or visitors, relatives, or even staff. On the other hand, you have patients who are subsymptomatic. These are patients coming in for for other problems. We saw a lot of psychiatric patients. We saw a lot of trauma patients who came in. And if we hadn't screened those patients, we wouldn't have missed most of the patients just complaining about a little bit of cough, complaining about fatigue in the last days. But when we did the screening, we finally identified them of being SARS-CoV-2 positive. However, when we speak about identifying those patients, I want to focus on those patients who truly appear with COVID-19 disease, and we saw typical and atypical presentations. So what is the typical presentations? And as always, the history tells you most. And please consider also when interpreting these, my experience is that we saw those patients quite early in their disease course. So after a 2 or 3 days history of disease, and not as many of the practitioners in low middle income countries only when the patients are severely sick. So I will summarize our experience in the emergency department, and this includes non-critically and critically ill patients. And the history usually involves patients reporting dry coughs. For those Austrians who measured fever, which most didn't, some of them reported fever, many of them reported chills as a subjective representation of having had fever. Shortness of breath is common. Complaining of dyspnea, however, was quite uncommon. Fatigue was a common symptom, as was a change of taste or the smell. A loss of taste or smell has been rarely reported. It was usually something like we taste metallic, the food does not taste anymore. Similarly, as there was a lot of debate about diarrhea being as one of the features of COVID-19. It is, but it is not a gastroenteritis type of diarrhea. It is patients reporting loose stools maybe once or twice a day. Same, the histories of many came to the hospital having been pre-treated for respiratory infections with antimicrobials, for example. These were usually patients presenting later than the others. Also, a very, very strong predictor, as mentioned before, are a patient living together or having had contact with sick household or family members. Same was a contact to sick person or a visit to region with a high prevalence. This was in our case, the Western Austrian and Italian region. So when it comes to the physical examination and you examine those patients, the key thing is you don't see a lot. And what we were most impressed about is the severity of hypoxemia those patients present with. Even after a quite short course of the disease, hypoxemia can be severe. And as it's a clinical symptom, a symptom which can clinically be only recognized at a severe stage, I would suggest to measure saturation at your triage points, because we were amazed to see patients in little distress, but with saturations in the 70s or even lower. If you look closer at those patients, nearly all of them are tachypneic, but they report fairly little dyspnea on the other hand, also which represents in a physiological breathing pattern. When you auscultate those patients, you find a characteristic fine crepitations over both lung bases. It's different to that heard in pneumonia. Maybe the most comparable sound is that of congested lung in patients with heart failure. And one thing we also learned is that you especially find it in the sitting position. You rarely hear it in the supine patients, and if they are mechanically ventilated, it's even rarer to hear. Otherwise, the physical examination is quite normal, and you will not find a lot of other features, especially early in the disease course. Fever is not seen in all cases at hospital presentation, although the data from the big databases shows that almost 90 to 95% of patients finally present with fever. Our experience is during the first 24 hours after hospital admission, fever was highly prevalent, but usually not at that case when you examine the patient. So don't make any decisions on the risk factor if the patient has fever or not. The lab pattern is something which is truly characteristic for COVID-19. As mentioned before, if SATs are low, usually PaO2 is decreased as well. And in a compensatory effort to reduce or to increase the alveolar PO2, PCO2 is decreased in the blood. And this is represented by the tachypneic patient. White cell count was usually normal, only slightly elevated, but as Armand has already referred to, lymphopenia is something which is highlighted. Also, mild thrombopenia is recognized at admission. Most intensivists would not even notice that. It's around 120, 130, or even higher of platelets. What almost all patients had, and I can only repeat, the higher, the more severe the disease was the elevated C-reactive protein. Armand before has stressed the increase of IL-6, and IL-6 as a physiological stimulator of C-reactive protein might be the reason behind that. For all those who have procalcitonin at hand, as we are lucky to have, we almost always found negative procalcitonin levels in those patients when they presented to the hospital. When we admitted them to the ICU, some of them had elevated procalcitonin levels, indicating that superinfection, bacterial superinfection, may play a role when it comes to secondary deterioration or severe disease. Also, something which was not so much reported in the literature so far is mild hyponatremia. So it's around a sodium of 130, 128, 132. So these were the ranges we saw in the emergency department when those patients arrived. Elevated lactate dehydrogenase levels likely represent the cellular destruction in the lungs and are frequently seen, especially in those patients who need to be hospitalized. You usually see levels about 250 units per liter, and when they arrive at the ICU, we have seen rare cases of patients usually above 300, some rare above 400 units per liter. Also, Armand has stressed the elevated D-dimer levels, and they are elevated in almost all cases which require hospitalization and definitely increase in all patients who are in the ICU. We also found several patients having PEs, and soon after the first literatures came out, we started to therapeutically anticoagulate the patients. What we only sporadically saw at emergency department admission was elevated creatinine, liver enzymes, and CK. When it came to ICU admissions, many of them had elevated creatinine and liver enzyme levels. Once again, keep in mind that patients in Austria present very early to the hospital. So in other settings, these laboratory abnormalities may be more frequent. So when it comes to radiological images, definitely what we can say, X-ray helps. X-ray helps because, as you see here, typical patients with those subpleural changes, they definitely appear interstitial, and you don't see any major pulmonary venous congestion in this patient. So that's something, if you see a picture like that and you haven't seen it clinically, or the clinical appearance wasn't that impressive, go back and have a look again, and you often find typical clinical findings. Also, lung ultrasound is a very helpful and sensitive method to find or identify patients suffering from COVID-19. And as you see here, the range is wide. You see B lines, especially at the lung bases. You see flashlights or several B lines or even whiteouts in some patients. If you look closer at the pleura, there is irregular or thickening of the pleura and some subpleural consolidations, which, given the heterogeneity of the disease in the lung, cannot be seen on all pictures of the lung ultrasound. CT scans, once again, a very practical experience, is a sensitive method. So you will always see something on the CT scan if your patient has COVID-19. But our experience is it does not really help you to tell that this patient has it or this patient does not have it. So in the end, we'll end up with the challenge that many radiological images, also the CT technique, remains unspecific in the end. This is a very specific picture, also explaining why auscultation and ultrasound will give such a high sensitivity, because the lesions, the alveolar lesions, are typically lying in the subpleural area of the lungs. And then for the last 2 or 3 minutes, I would like to share some of our common errors in the beginning, especially when the COVID epidemic entered Austria and all hospitals started to prepare for it. No one of us has ever seen it, and we were chasing a phantom. So none has seen the typical symptoms, but be sure after you have seen 5 of them, you will recognize most of them. So we had the problem of fixation error. So everyone who came in with fever had COVID, but in the end, they turned to have a lot of other diseases. And our top hit list at the hospital here in Linz was, in the beginning, we often misinterpreted congestive heart failure as patients of COVID. When COVID hit us, we were still high in the influenza epidemic in our country, and influenza and COVID sometimes coexist. We saw them. They're usually more sick, but they are difficult to exclude from each other. Also, atypical pneumonia, don't forget it, and also during an epidemic, patients will present first with interstitial pneumopathy. So always keep an open mind. Be sure if after you saw some COVID patients, you will recognize them again, and also keep your differential window in the beginning wide. And then for the last picture, let me come to the atypical presentations, which we saw. They are not very frequent, but we saw a couple of them. This is related due to the coagulopathic character of the disease or the virus, inducing, as we heard from Armand, both endotheliopathy and the massive stimulation of the coagulation system. You can see here a patient with large vessel stroke. These are usually patients who have some symptoms. So if you go through the screening lists in these patients, most of them has 1 or 2 of the symptoms positive, but they don't present because of that. They present because of stroke, because of severe pulmonary embolism, or because of STEMI or acute coronary syndrome. So we suggest, or our experience and conclusion is that in any patients with a thromboembolic event, we specifically screen them for any symptoms of COVID-19, and we liberally test those patients. And we were amazed to see that many of those, or a substantial part of those patients, was positive. So my take-home messages are: the diagnosis of COVID-19 is based on laboratory confirmation. Watch out for false negative results very early, but also later after 10-14 days after infection. The typical clinical presentation varies, or the clinical presentation varies from subsymptomatic over typical to atypical. The typical COVID-19 patient is a characteristic disease pattern, which you will find out by listening to the history, having a good look at and performing a solid clinical examination, screening your laboratory parameters, and taking those radiological exams you consider necessary, because radiological exams or features are sensitive but unspecific, so do not overrate them and don't think everyone has COVID. Consider therefore important differential diagnosis also during a pandemic. And finally, remember that there are atypical presentations. They are rare, but I'm sure you're going to see them. Thank you very much for your attention.
Thank you very much. Thank you very much, Martin, for this excellent presentation. I remembered one anecdotal moment when you were talking about the CT scans, that they are sensitive but unspecific. I was receiving a telephone from the radiologist saying that there was the CT scan of the patient was absolutely typical for COVID, and we had only at that time 7 or 8 COVID patients with the first or second CT. So I was just asking him how we could decide on that, and I would just immediately relate this to the first question. The way the speaker is presenting, he is implying chest radiographs are better than the CT scan and ultrasound. Is this what you wanted to indicate, Martin?
No, thank you very much. It's a very, very good question. That was more from a practical point of view. So if I could choose, I would do a CT scan on every patient with a suspicion of COVID. It's just that it was the X-ray is much more liberal to get. It's much more accessible, and already can you tell something, but it's much less sensitive as the CT scan. So about 50% of patients will have a clear X-ray. But if you see symptoms, it's usually the CT scans did not really help us. Sonography was very accessible and highly available at the bedside, so it's very easy to use, but it's better than the X-ray. But finally, I mean, from a sensitivity point of view, the CT scan is definitely the best one. From a practical point of view, I would start with sonography over X-ray and then go to the CT scanner.
Okay, there is one more question, and the person who has asked the question says, could you please share the references regarding this mismatch between dyspnea and hypoxemia? I've just heard this in meetings, but I could not find a case series or a cohort with deep analysis in symptoms and signs.
Yeah, that's also a good question. So as I said initially, that's a pragmatic, practical talk on our experience. And I can't give you the reference. We were collecting data, and I hope that we can publish them.
Okay. Mervyn, shall I give the word to you, either for a question or for the next speaker?
A couple of quick fire questions, Martin. As you know, we both have a passion for clinical application in critically ill patients. And you would all have heard the term that all good students of medicine listen, look, touch, so that they can hear, see, feel, and interpret. And that's very relevant. So thank you for sharing those sort of issues. Was there anything...
Just like in the old days, not Mervyn.
Exactly. Was there anything you looked at? One of the fascinating issues that I picked up recently, and that we've seen intermittently, even in the resource-limited setting, some work coming from Spain, was looking at the patient's hair. And in fact, a number of studies now that have been published suggesting that bald-headed males have a higher incidence of severity. Any comment?
That's a very, very good question. I love it. I love the association. To be honest, we didn't see that. I mean, when at the moment we see very few patients, so these data or these experiences came up after we saw our surge of patients. So I can't really comment on that because I didn't look at the haircut at that time.
No, excellent. One of the things you mentioned was a broad differential diagnosis. And again, in resource-limited settings, there is a need to apply excellent clinical acumen. Amongst your differentials, you included congestive heart failure, certainly in the winter months that many of us are now experiencing, bacterial pneumonias and other entities. Is there any way at the bedside that you could get a clue, because you've already alluded to the fact that, in fact, false negatives are not uncommon. And perhaps just a second issue before we close, you could comment on what conventional testing should be, what is the best way to do it, and what are the false negatives, and how can clinical acumen assist you in excluding from a clinical basis the likelihood of a COVID-19 disease?
Thank you very much, Mervyn. So for a first, I think congestive heart failure, a good clinical examination can exclude, I would say, 90% of those patients. However, we all know that some patients are in isolated left heart failure and are not really congested. Then I think clinically it's very difficult to exclude COVID in these patients. Usually the X-ray help and the sonography and echocardiography help. But I would lie if not to say that some patients were only, it was clarified by the NT-proBNP levels which came back from the lab. So there is a, I would say, margin of unclarity in some patients with heart failure. And regarding the, did you relate to the COVID, to the SARS-CoV-2 testing?
Yes, and perhaps the bacterial pneumonias, because they tend to be unilateral with typical air bronchograms on a basic chest radiograph. The congestive heart failures often displaced apex beat, third heart sound, mid to late end expiratory crackles, which are evident the JVP may be elevated, etc. So we found that particularly useful and in fact correlated that very distinctly with testing. And in fact, I think we were correct 90% of the time. You can't always get it correct, but good clinical acumen gives you a very, very good idea. What is the optimal test that one should be doing up front to try and confirm the diagnosis?
So from a laboratory perspective?
Yes.
So we did nasopharyngeal swabs, and if the clinical and radiological appearance was highly suggestive and the test was negative, then we usually did a bronchoscopy to get deep tracheal secretions.
Okay, any comments on saliva or sputum in a resource-limited setting, because bronchoscopy may be somewhat difficult?
We haven't performed saliva testing here, so our test was not calibrated for that, and so I can't report on experience with saliva testing, which I think would be the optimum because it's easily accessible and non-invasive.
Thank you. I think that is the point. And certainly sputum testing, the yield is far better actually than with nasopharyngeal sampling. But I think those are some of the pragmatic issues that people out there may want to take on. And just thank you for an excellent overview. Really enjoyed that as always. So thank you very much, Martin. We're now going to move on to the next talk, which is looking at respiratory support in low middle income class countries, and Arthur Kwizera is going to address that. Arthur is a Ugandan anesthesiologist and intensivist who serves as a senior lecturer in anesthesiology and critical care at Makerere University College of Health Sciences in Uganda. He's also a staff intensivist at the Mulago National Referral Hospital in the intensive care unit in Kampala in Uganda. And he advises the Ugandan Ministry of Health on various scientific matters, and is regarded really as one of the doyens, certainly in East Africa, to address many issues. He also has a very significant link at the present moment with Cambridge University, and part of the work that he's in fact doing is the development of a ventilator that could be utilized broadly in resource-limited settings. So Arthur, it's as always lovely to see you, and we look forward to your talk. And thank you for all your ongoing contributions.
Thank you very much. Yes, I was given the honor, and I thank you guys for letting me have contribute to this. It is not a very easy subject to talk about, especially in the context of resource-limited settings. I have no disclosures to declare. Right now, as you can see, COVID cases are rising in Africa, and I believe this webinar has come at a good time where we can share across the board. We still do not have any COVID severe ICU cases in Uganda, or deaths for that matter. Epidemiological measures seem to have helped, but we pray that doesn't happen. So I'll go straight into the basis of what I'm going to talk about, the fact that we all know that our critical care capacity in Africa is significantly reduced. We have very few ICU beds per 100,000, and that figure I've shown is might be optimistic. In sub-Saharan Africa, we have less than half a ventilator for 100,000, and then the key people that provide acute and critical care in Africa, who are the anesthesia providers, both physician and non-physician anesthesia providers, as you can see, are also very, very few. There has been some little data that has been collected regarding the number of qualified anesthesiologists by country, and this I have already shared data from the WFSA. So the first thing that we know is that human resource limitations exist. So skilled people to provide respiratory support are still very few. And it's even from this data, you can see that it tends to trend too much with income group. So when you look at the data, critical care capacity is higher in high income countries. So you'll have countries such as South Africa and the North African countries like Egypt and Morocco having a higher volume of ventilators and anesthesiologists or intensivists and ICU beds for that matter. And when we see a study that was, this was actually conducted by Reuters. I participated in this where they interviewed every country. You will see across that that the care capacity in terms of ICU beds is really, really low. You know, there's data from some countries where they had no ICU bed, and that portends very poorly for outcomes. When you look at the ventilators that could need to be, so you had again Reuters reporting ventilators that needed to be available in the peak of the pandemic, according to estimates by the Imperial College of London. South Africa, which has the highest number in Africa, for example, would need to almost double or more their capacity. Again, Morocco, Ethiopia, Nigeria, and as the list goes down. Our country, Uganda, we do have about 100, but from our estimates with the Ministry of Health, we realize we probably need about 1,000 to 1,600 ventilators just to manage the peak of the pandemic should it hit our country. So what happens? Outcomes of poor capacity. That means that in patients with acute hypoxemic respiratory failure, whether it's due to COVID or non-COVID, have very poor outcomes. We did a study in Uganda where we looked at patients with acute hypoxemic respiratory failure, and of the 327 patients, only 6 got access to the intensive care unit and mechanical ventilation, with an in-hospital mortality of 77% and a 90-day mortality of 85%. So it is on this basis that I'm explaining why that I'm going to continue and looking at what options do we actually really honestly have. I was supposed to talk about mechanical ventilation, but it's for low-income countries that might be a bit, I'd deal with what we actually have available and what might be readily accessible. So of course, the first thing you want to do is optimize your standard oxygen therapy protocols. And then of course, you have the other options, non-invasive ventilation or CPAP and high flow oxygen therapy. And then I'll make a special mention about the Buzniak CPAP system, which I recently discovered. So to optimize standard oxygen therapy, the indications, and I'm discussing this with a view that we have a lot of colleagues from low middle income countries. There's not a lot of data from low middle income countries with regards to what's better, and therefore this is more of a practice-based discussion rather than, which has some evidence, but it's medical common sense. So one of the things that we are trying to focus especially is in the hospital setting, give oxygen immediately to patients who you suspect who have acute hypoxemic respiratory failure as part of severe acute respiratory infection. And of course, patients in severe respiratory distress, patients with septic shock, patients who have altered mental status, or if pulse oximetry with those values, you do not delay to give oxygen administration while you're investigating the causes. And of course, if a patient is critically ill, we're recommending that you give higher flow rates. So in adults, it's better to start higher, sort of like what you do in the ICU. When you intubate the patient, you start with a high FiO2, and then start to titrate downwards till you meet what their requirement is exactly. And then, of course, in the less ill patients, you can start at 5 liters per minute by nasal cannula. Patients who, with COVID-19, now that we are in this era, we have to have a high index of suspicion. And so even though they look well, because we've read about the pre-hypoxics, please start with high oxygen levels by face mask and reservoir bag as you find pulse oximetry, or if you have resources, do a blood gas. I've put something in for the children, even though they have quite lower rates of COVID disease. The maximum flow rates usually we prefer to provide with nasal cannula. If they need more than 6 liters, then you have to consider higher care, CPAP, and a secondary source of oxygen, the face mask or reservoir bag. I'll just talk about proning. Proning doesn't have a lot of data of course, in this pandemic. There are trials that are coming up, but physiologically it makes good bedside medical sense to do it. It's proven in intubated, ventilated patients, so it should be able to work in our setting, and we would recommend this highly. Again, when you have children, you have to seek assistance from nursing staff and family members. Kids can be very irritable. And when you're using nasal prongs at standard flow rates, you do not need humidification and so on. So I also implore, and do not forget to monitor oxygen levels. The clinical signs are not always reliable indicators of hypoxemia. It is very, very important that your facility, or that our facilities, should have pulse oximeters so that we're able to make a diagnosis as well as monitor oxygen levels, and so that you titrate oxygen therapy. If you have a blood gas analyzer, even if it's in the ICU and you don't have ICU space, you can still use it to measure patients' indicators of hypoxemia, even if they're in the emergency area or in the ward. And of course, titrating oxygen to reach a target of more than 90% in adults and children, with consideration for pregnant patients, and more than 94% for a child or adult who has signs of multi-organ failure, including shock, altered mental status, severe anemia, and resuscitation, and then you can resume the target of 90. And obviously, you win oxygen when the patient is stable. Why? Because one, it's a very, very, very precious resource which can be wasted, but also it may have too much oxygen, may harm the patient. I put this, I'm trying to make this as simple as possible to titrate oxygen and what the appropriate doses and devices are. I would recommend, especially in the setting of COVID, to go straight for the high dose, which is the non-rebreather bag, mostly because usually you're alone and maybe with one nurse, and you do not have the resources to de-escalate or escalate care. So in situations like that, I'd recommend you just go straight for a non-rebreather bag and manage oxygen therapy with this patient like that. And then, of course, in this setting now of COVID-19, we have to consider infection control practices. And that means that we cannot reuse these things. And then humidification is not necessary when delivering low flow rates, especially in a situation where you have high aerosolization. And then, of course, avoid bubble bottles. I would also, obviously, it goes without saying that personal protective equipment for the health worker should always be considered. And patients who do not respond to increasing oxygen therapy are developing acute hypoxemic respiratory failure. And I have outlined that in the setting where you do not have a blood gas and using the SP-FiO2 ratio of less than, it's actually 315. But if it's less than 300 while on at least 10 liters per minute of oxygen therapy, and you do not think cardiogenic pulmonary edema is a likely cause, you have to escalate care. That means that you either refer the patient to a facility that can provide higher care, or do it yourself if you have the. So what are the available options? I will talk about non-invasive NIV, continuous positive airway pressure. There's a lower risk of nosocomial infections, especially in low-income countries where antibiotic access can be a problem. There's less antibiotic use, less need for sedation. In the Lancet study in ARDS, they found that NIV was successful in about 15% of these patients. However, in patients who failed NIV, they ended up with higher mortality rates. There are various contraindications, such as level of consciousness, and obviously, if a patient needs sedation, if the patient has an NG tube, it can be, and of course, patient cooperation and salivation are relative contraindications. So in the first few hours, you have obviously the standard for application of NIV during the first few hours. You explain the technique to the patient, you choose the correct interfaces and size, you set your pressure starting from lower levels, you place your interface gently over the patient, and you allow the patient to apply the interface themselves. When the patient is tolerant, then you can tighten the straps just enough to avoid major air leaks. So the care of NIV has a sequence that I've outlined here, and it's imperative that you follow it. Of course, always be mindful for side effects, for complications such as pressure sores and patient discomfort. You may consider using mild sedation. If you're going to use it for longer than 6 hours, I recommend that you try to humidify. So I have already spoken about this. The Buzignac CPAP system is something that I recently came across. The system, I think, is quite popular in France. I was introduced to the system by Amand, and it seems to do quite a good job. One, it's cheap. It does not need electricity. It comes in 4 different sizes, so from children on to adults. You can use it with a nebulizer, and you can actually, if you do not have a compressor for medical air, you can actually do a direct connection to an oxygen regulator, and it can give you between 5 to 10 centimeters of water at about 20 liters per minute of the regulator from the oxygen cylinder. Again, you use it with the same principles of NIV. Just to mention, the challenge with NIV is that you have to adjust the pressures to avoid expired tidal volumes of more than 6 mils per kg. Then there's, of course, high flow oxygen system for acute hypoxemic respiratory failure. This is also relatively cheap, doesn't have to be used in the ICU, and it can be used for adults and patients. The Flow Rally trial compared it with NIV and I think standard oxygen, and there were some benefits. Again, I said this in the sense that this would, in many places in middle-income countries, this would be the last resort where there are no mechanical ventilators. And this is why I have emphasized this. So it's the advantage of the high flow oxygen system is a comfortable nasocannula interface, reliable titrates, oxygen up to 100%. It gives high flow rates, and humidification prevents dryness. You can also use it in infants and children. The advantage, one really good advantage, is the washout of the nasopharyngeal dead space means that you have relatively lower CO2 and less dead volume. And then it does provide some PEEP. Again, I would consider proning patients to improve distribution of oxygen to the lungs, and you monitor closely for the need for intubation. If there's nothing you can do, then the other thing I need to advise is to consider the issue of comfort care. We have a pathway that we have developed in critical care management for Uganda. I'm going to speak about our Ugandan experience. And in these situations where you have a patient where you have non-invasive or high flow, non-invasive by CPAP or by some chip device, you restrict fluid resuscitation, you consider a wake-prone position, especially in patients with alveolar collapse. If there is no alleviation, obviously, you have to consider mechanical ventilation and all the more expensive therapies. If you do not have it, then I would also consider comfort care and some sort of palliation. So we have future studies for oxygen therapy in low-middle-income countries. We are about to start the ARISE trial, which is comparing high flow to CPAP to standard of care. The COAST trial is done, and there should be a publication out soon. The BREATHE and the COASTA trial will come later after the ARISE trial. These are basically focused on what the appropriate oxygen therapy, at least in Africa, would be in resource-constrained settings. So Uganda's experience, we tried to come, because oxygen is also a very important aspect, and I had to talk about it. We came together as a team of technical advisors and the Ministry of Health, one, to quantify oxygen requirements for both COVID and non-COVID care, but also planning for equipping and staffing 18 new 10-bed ICUs around the country. So obviously, we had to have the knowledge of how many tanks you require for 24 hours of oxygen administration. As you can see, because we use this methodology to help us calculate. Most common oxygen cylinders in Africa are usually the 6,800 liters or the 7,500 liter tanks. So as you can see, the higher the flow rate, obviously, the higher the consumption and the higher the tanks that you need. Then again, depending on the kind of care that you're giving, we then went and looked at how many cylinders you would use per day, depending. As you can see, high flow nasal cannula for one patient who is quite ill at an average flow rate of 40 liters per minute, you would need about 8 cylinders per day, which obviously it can be quite expensive and quite tedious. So just as an example, we then came up with a scenario where we said, okay, let's look at the maximum number of patients per day that would need, that would treat with the available resources at the time. So we created 2 scenarios, and this is just because I'm, from an African scenario, this is the reality. That, in one scenario, if you had 30 dedicated, COVID beds, level 1 patients in terms of severity and so on and so forth, we then calculate, and then we also had a second scenario where we had 30 dedicated beds, 20 non-COVID beds, that means surgical care, obstetric care, children with pneumonia, and so on and so forth, and then 10 ICU beds. You could see that we calculated total oxygen volume, which was almost double. So this was to help my colleagues in low middle income countries when they want to do oxygen quantification as well, because this is something very important to us. We usually don't have biomedical engineers, and so you've got to take these matters into your own hands. So in summary, there are low-cost options to provide optimal oxygen therapy in low middle income countries. It's very imperative that we judiciously use pulse oximetry to detect hypoxemia early, especially in the area of COVID. Consider proning in all patients without contraindications, and consider a national referral pathway for critically ill patients. And then, of course, training and recruitment, healthcare systems training is very important, and that as well as planning oxygen delivery according to your supply capacity. Thank you very much.
Thanks very much, Arthur. Joseph, would you like to kick off? I have a few questions, but I think we are cycling things, so it's relevant for you too.
Okay, I was mute. I was asking, but you couldn't hear me. I'm sorry about that. There was one question that I would like to ask coming from the audience, which I thought it might be an interesting question. It says, given the shortages of critical skilled staff, limited access to oxygen sources and monitoring equipment, challenges of ventilating ARDS patients, how envision greater access of ventilators go to positively impact outcomes without being able to improve the other limitations to critical care?
Can I answer that now?
Yes, please, if you want.
Yes, exactly. And that is why the basis of my talk, I try to avoid the issue of mechanical ventilators. We try to stick to the basics of all these alternative oxygen therapies that are more readily available. It's easy to train lesser skilled staff on these than mechanical ventilation, and it's going to be difficult. The truth of the matter is, countries have to invest in oxygen capacity, as whether they like it or not, so that we're able to start to create a foundation for improved respiratory support.
Okay, thanks. Mervyn, you just please go ahead before we end up the session.
Thank you very much, Joseph. So thanks very much, Arthur. I mean, there's certainly are massive challenges in terms of logistics and infrastructure, and ventilation is in many instances non-feasible. However, you did mention various non-invasive devices, and a question from a member of the audience as well, viewer, is if you do have access to high-flow nasal oxygen or BiPAP or CPAP, which is preferable?
Okay, I think so philosophically, the data seems to suggest that high flow is more comfortable for the patient. However, the reason I talked about oxygen capacity is high flow really drains your oxygen supply. If you have unlimited oxygen, I would go with high flow. But as you can see, high flow CPAP maybe takes about maybe a third to a half of what high flow would take. So in the case where I have limited resources, I would go with high flow, with CPAP, sorry. The Buzignac system that I just showed doesn't even need electricity. So it depends on the resources available to you. If you have an oxygen generating plant, which obviously has a relatively more abundant supply and is not cumbersome for cylinders, you may double with high flow, but you have to really care to be very pragmatic and to think through every therapy that you're applying.
Are you worried about aerosolization with non-invasive ventilation, either high flow or any of the other options you mentioned?
Yes, of course. I did mention that you have to take into consideration some of the precautions that you have to take. In the data, again, that I saw a paper about a month ago that was looking at comparing aerosolization. If you have a good interface between on high flow or on CPAP, CPAP I think is marginally better in terms of preventing reduced aerosolization, but you would really have to protect the healthcare worker at the end of the day. There are many factors that come into play.
Right. Perhaps I could just share some of our own experience again in a resource-limited setting. In fact, in our setting, we've only got 4 high-flow nasal oxygen machines. We have very limited CPAP. And again, despite the issues, ventilation somewhat limited, but we get by and we're trying to be pragmatic. We're finding high-flow nasal oxygen exceedingly useful, very, very useful. And we also do have limitations of oxygen capacity. But we are trying our best to get through those sort of elements. We place a surgical mask over the patient's high flow interface. And again, a very useful, very important issue for everyone to take out, because most of us don't have access to negative pressure facilities. So in fact, what we do is we open the windows. You get great air exchanges. In fact, at least 12 per minute. Which is good. It's most negative pressure or extraction devices. So I would advocate that. And then the proning. I just want to share this because there may be people out there in whom we can share some of our practical learned experience. And in South Africa, things are ramping up very significantly. We really are flooded here at the present moment, and it's likely to get even worse, is that proning, when patients, we often have younger patients as opposed to perhaps other parts of the world. So what we're doing, instead of trying to turn a patient on their left side, right side, stomach and so on, get them to sit up or stand. It's the best way you can expand potentially as lungs. Very simple. And I've not seen that described, but I can tell you that it works. We, in fact, currently have, believe it or not, in Africa, now sharing this with Martin, a 270-kilogram patient in the ICU, no option of ventilation, and we're managing quite adequately with getting him upright and standing him, and the saturations improved dramatically. He's a young man, so in fact, he's able to do that, and that's been our experience as well. So those are just some practical elements, and then the final issue that I think may be relevant for everyone who might be listening: get in early. Get in early. And that's often a major problem in resource-limited settings. And very often just conventional nasal cannula will take you a long way. So just a few issues. We really enjoyed your very pragmatic and comprehensive overview. So thank you, as always, Arthur, for making a very significant contribution to this webinar.
Thank you, Marvin.
Thank you.
Nice to see you again. Thank you, Joseph. Thank you very much.
Okay, I think the first session of our webinar is now coming to an end. Thank you very much for listening. And after a very small pause, we will go on with the second part. I'm an anesthesiologist and I'm proud to be an intensivist. We, intensivists, are working together to fight COVID-19. Together, we are intensive care medicine.
Hi, I'm proud of being an intensivist. We are fighting COVID-19. Together, we are intensive care medicine.
I am an anaesthetist and I'm proud to be an intensivist. We are working together to fight COVID-19. Together, we are intensive care medicine.
I am an intensivist and proud of it. Intensivists with various specialty backgrounds work together as a multidisciplinary team to prevent and treat temporary risk of death due to COVID-19.
My name is Jan de Waele and I'm proud to be a surgery-trained intensivist and work in intensive care. We work together to beat COVID-19. Together, we are intensive care medicine.
Hello, everyone. Hello, Mervyn. I am Maurizio Cicconi, and the President-elect of the European Society of Intensive Care Medicine. I'm very happy to be here with Mervyn Mayer. He does not need more introductions today, and so it's good that we are sharing this session together, Mervyn.
Thank you so very much, Maurizio. It's actually a delight, a pleasure, and an honor. Thank you. We're going to move on to the next speaker, and that is Professor Flavia Machado. And Flavia is Professor of Intensive Care at the Federal University of Sao Paulo in Brazil, where she's also head of the Intensive Care section of Anesthesiology, Pain, and the Intensive Care Department. She's trained in internal medicine, infectious diseases, and critical care, and really has become globally known for her contributions. She's one of the founders and now currently the CEO of the Latin American Sepsis Institute, also known as LACI, and in fact has also been its president. LACI is devoted to the awareness, raising quality of improvement in Brazilian hospitals and the coordination of multi-center studies in the field of sepsis. She's also part of the executive board of the Global Sepsis Alliance and the executive committee for the World Sepsis Day. And she served on the board of the Surviving Sepsis Campaign International Guidelines and the International Sepsis Forum Council since 2014. She's also a member of both the executive and scientific committees of the Brazilian Research and Intensive Care Network, called BRICNET, and is additionally the editor-in-chief of the official journal of the Brazilian Critical Care Association and the Portuguese Critical Care Association. And today, Flavia is going to address the topic of therapeutic principles and other considerations in the context of COVID-19. So Flavia, lovely to see you. Thank you so very much for making yourself available, and we definitely look forward to your talk with enthusiasm. Thank you.
Hello, Mervyn. Hello, Mauricio. It's a pleasure to be here and try to bring a little bit of our fight against COVID and how we can do this. This is not impossible. It's our goal to turn this into possible. As we know, there is a lot of case series and very nice reports on how our patients die. But I try to bring to you the first 150, very far away now from the first 150 patients, and how they die. And as we can see here, 70% of them died from refractory septic shock, stroke, arrhythmias, MI, bleedings, pulmonary embolism. Not a single of our patients died from refractory hypoxemia. And the reason is because they are dying from sepsis, either the sepsis from the virus or from a superimposed bacterial infection. So the way to look at this and to see the treatment options that we have is to see the treatment options that we have for sepsis. How can we avoid this? Following guidance, looking at the evidence-based treatments, and I will bring a summary to you for what we have from the Surviving Sepsis campaign and also from the WHO clinical management guidelines that was just released a couple of weeks ago. We'll try to address a little bit of hemodynamics, antiviral therapy, adjunctive therapy, talk a little bit about infections, and also, and maybe most important, how can we keep going, enhancing the quality of care in the middle of the calls. About hemodynamic management, the guidelines coming from the Surviving Sepsis campaign are pretty similar to the guidance that we have for sepsis. But as you can see, most of this we can do in resource limit settings. There is a recommendation to follow dynamic parameters, which includes perfusion assessed by skin temperature, capillary refill time. Of course, if you have lactates, you can also do this, and to use these dynamic parameters over static parameters. There is a recommendation to be conservative regarding fluid strategy and to give crystalloids over colloids, which are all feasible in our settings, and we are all aware about the potential harm of being liberal with fluids in resource where there is no backup of mechanical ventilation or from ICU. You can use balanced crystalloids, but there is a recommendation against using starch, gelatins, dextrans, and also albumin for initial resuscitation. And all these are much more expensive than the basic crystalloids that we should use. Regarding vasopressors, the recommendation is to use norepinephrine as the first line agent, but if it's not available, either vasopressin, which is most of the times not available in resource limit settings, but we do have adrenaline, and there is a recommendation against the use of dopamine, except of course if norepinephrine is not available. If you can add a second line agent and vasopressin is available, this is going to be a good strategy to titrate all these agents to a MAP, a mean arterial pressure of 1665. Using dobutamine only if there is signs of cardiac dysfunction, and to associate corticosteroids for refractory septic shock. So this is feasible. The most of the time we do have this in our resource limit settings. WHO follow more or less the same guidance of the Surviving Sepsis campaign, again advising for caution in the fluid management of these patients, most where there is no backup, and give small amounts of fluids like 250 to 500 ml of crystalloids, assessing again before giving any additional fluids, based again on clinical response and the improvement of perfusion targets. Again, we are not talking about all these advanced monitoring strategies that we have to assess fluid responsiveness. They can be used, but I believe we are all aware that they are not easily available in our settings. Regarding antiviral therapy, both guidelines are very clear in saying that there is no evidence to use any of these, and this should be used only on the context of clinical trials. Chloroquine, hydroxychloroquine, azithromycin, any of the antivirals immunomodulators like tocilizumab, and plasma therapy. And we are all aware about the high costs of some of these therapies and that they will not be available for the majority of our patients in our settings. The Surviving Sepsis campaign said the same thing, that there is no sufficient evidence to this and made no recommendation to use any of these therapies at this moment. And how about corticosteroids? This is very interesting because this is probably one of the most controversial therapies that we have at this moment. Because as you might know, there is some evidence for the use of corticosteroids in ARDS, non-viral ARDS. There are systematic reviews saying that they might help. And now the issue is, can these results, this meta-analysis, these results reflect what is happening in a patient with a so severe viral pneumonia? So this is why we can see, for instance, differences between the Surviving Sepsis guidelines and the WHO. Surviving Sepsis clearly states that it's a weak recommendation, but not to use routinely corticosteroids in patients without ARDS. But they say, and it's a suggestion, a weak recommendation because of the level of the evidence, to use it when the patient has ARDS. By contrary, WHO did not recommend the use of systemic corticosteroids, except, of course, in the context of clinical trials. And maybe what based this decision is the potential harm regarding the replication of the virus. We are all aware that COVID-19 is a very thrombogenic disease. So there is a recommendation from WHO to use pharmacological prophylaxis to prevent venous thromboembolism, but most important, to monitor those patients regarding thrombogenic complications, such as stroke, deep vein thrombosis, and pulmonary embolism. We are seeing all this happening in our patients. And so if this is clinically suspect, certainly the appropriate diagnosis and management pathways should be started. And how about giving antibiotics to this patient? Again, this is not so simple. On the Surviving Sepsis guidelines, they suggest that in mechanical ventilated patients with COVID-19, with respiratory failure, which means in mechanical ventilated patients, they suggest we should use empiric antimicrobial and antibacterial agents. WHO is a little bit more conservative. They think that this should be done only if there is real clinical suspicions of bacterial infections. And this poses a challenge for us in resource limit settings because, as you know, we do have much higher incidence of multi-drug resistance in our settings. This is from WHO, and you can see here in Asia, in the data coming from Africa, and even in Brazil, this is different from the high-income countries in Europe and North America. So we are in a situation that our patients might need antibiotics, broad spectrum antibiotics, and this might contribute to resistance. In our country, in São Paulo, in many public hospitals, KPC is endemic. And now, for instance, in our unit, we are facing a lot of problems with PAN resistance, Klebsiella. So how to deal with antimicrobial therapy in the COVID-19 patient is a challenge, and it should be individualized, not only regarding the patient, but also where we are, in which institution we are. We should not forget important things. For instance, we were all focused on humanized care before this tragedy of COVID-19. But we should not forget this. We should keep going. For instance, all this aid, all the 8 points of the humanized care, and this was recently published in Critical Care Medicine, can be followed even in the conditions that we are now. Policies for visiting from the families. We are opening our ICUs before this, and now we are closing them. But we can use virtual visits. We can try to have presential visits. And in chronic patients that are there for weeks without seeing their family, or by the other side, the very severely patients that will probably die. Communication, it's of utmost importance. We need web conferences, not only to discuss among the healthcare workers in multidisciplinary rounds, for instance, but also with families. We need to have medical reports at least once a day, and we need to register this. We need a communication log to not forget a single patient. Following a script on how we are going to do this, and training our people in this new way of having relationship with the families of our patients. Well-being is always important, always. It was always important, and now it's even more. We need to have analgesia and sedation protocols, delirium prevention. We need to have our patients feeling good with photos, letters from the family, music. And how to have the family participating in the ICU. Maybe having web virtual visits and accessing those patients. And this is the same for the healthcare workers. I mean, psychological support is important, both for the relatives and for us, having group discussion. And most of all, spread the praise. I mean, we always have to say what we are doing for good, and complimenting people on what they are able to do in the middle of this pandemic. We need to prevent post-ICU syndrome, as we always did, minimizing sedatives, preventing delirium, doing early mobility, having psychological support for these patients. This is a little bit more difficult, how to humanize architecture when our ICUs are so busy and everyone is so devoting time to many other things, but it's feasible. But most of all, we need to establish very clearly our end-of-life care practices, following family expectations, patients' preference, and setting, just from the beginning, goals of care. All of this is totally feasible in our settings. We can do this, and we should try not to forget the humanization of care. And we should not try to forget that we are intensivists, and our ICUs need to have high quality of care. Maybe some of this has changed. For instance, we are not such worried about PPIs before, and now we are. We are very worried about this, but there is here another risk, which is sometimes the professionals are feeling so safe because they are all protected that they are forgetting basic things like hand hygiene, changing gloves, and contact precautions, because we still have our MDRs among our COVID patients in the cohorts for COVID patients. And everything that we can do to prevent healthcare-associated infections is of utmost importance, because this is a huge reason for death among our patients. As we know, some of them are dying from COVID in the beginning. But as I said, many of them are dying from bacterial sepsis later on the course of the disease. We need to keep our multidisciplinary rounds. And it's such more important now to keep the checklists, because as we are so busy, the chance for mistakes and for forgetting something is much higher. So this is quite important in the routine care of the ICU. Avoiding unnecessary medication, mostly nephrotoxic drugs. About 30%, 40% of our patients are in renal replacement therapy. And if there is something that we can avoid to reduce the chance of renal replacement therapy, this will be very welcome. Sedation, neuromuscular blockage, we know that they are needed, but they are prolonging the length of mechanical ventilation. Most of all, we need to search for benchmarking. We need to look at other ICUs, other colleagues, other solutions. We need to look how people are doing this and get us doing the same way if feasible and if appropriate. We need to use evidence-based treatments. Now, as you know, I don't know about other countries, but in Brazil, the media is terrible. They are deciding what works or does not work to treat COVID. It's no longer the scientists, it's no longer the doctors, it is the media. And this is terrible. And for this, we need clinical research. And we need clinical research in our settings to find answers that will fit on our reality. All of this can be made in our resource pool settings. We are doing this. We are involved in Brazil in many trials. It's a coalition between 6 hospitals and 2 networks, including BridgeNet. We just finished 2 RCTs on hydroxychloroquine and azithromycin. They are being submitted shortly. We are running a dexamethasone trial and also a tocilizumab trial, among other trials as well. But just to finish this, I would like to put this a little bit in context, which means how is it, and this is a very interesting article, how it is to fight COVID, the shortage, everything, the so severely ill patients, and together with the inequality that exists in our countries. Like here, if you don't have water and soap and alcohol, how can we fight COVID in ICUs? We will not. There is a shortage of everything. In São Paulo, the biggest and richest city of Latin America, even if you have money, so it's not a problem from public or private hospitals, we are missing propofol, bicarbonate, any neuromuscular blockage, fentanyl. This is quite interesting because on the first wave, the supplies for PPEs they were bad, and the industry, they recover from this, start to produce more, and now it is okay. But the pharmacology industry in Brazil, they could not oversee what was going to happen. So now you are facing this, and we are also, of course, facing the shortage of ICU beds in the public system. And this is my last slide. This is a sentence coming from the government of São Paulo. And he said that he delivered a lot of mechanical ventilators to our city. And he said that each respirator that he delivered mean a new ICU bed delivered to the public network. This is a completely nonsense. A ventilator does not make an ICU bed. What we need to make an ICU bed is a good team. So it should not be a privilege for any Brazilian citizen and for anyone in any country to have an ICU bed. This is a right, and we need to go for this. And for this, we certainly need a structure, but we also need a very nice and very focused team like we have here. So I want to thank all the people that are working in our ICUs in our hospital. Thank you very much.
Thank you, Flavia, and very nice talk as usual. We have some questions, but I think some questions you probably already commented, because I have a feeling of what you think about all these drugs without trials. And there was a question about ivermectin using in Brazil. Maybe you want to comment on that too?
Yeah, ivermectin, it's not licensed for COVID in Brazil. Any of these drugs are, but as I said, what is happening here, it's a media and a political pressure in the doctors to use drugs that are not, has not been proved effective or even safe. So some people are having ivermectin. They arrive at the hospital and they say, well, I already had ivermectin. The same with the hydroxychloroquine. And this is really very bad. I believe that this will stop with the publication of the upcoming trials, including ours. But there is something, what is worst, Mauricio, is the political thing behind this, because our president wants to be the guy that will provide the cure for COVID to all Brazilians. So it doesn't matter that we publish trials showing that hydroxychloroquine does not work, and even it's harmful for the patients, he will keep going. He changed 2 ministers of health because of this. So as I said, I think that the worst thing is media. I'm not sure about other countries on Africa, but here is really very bad.
Well, I suspect close to the pandemic of the coronavirus, we're seeing a pandemic of off-label drugs, compassionate use of drugs, very often without evidence. I think that's been my experience here, but having done now many webinars and many talks with several colleagues, I think that's probably been one of the most difficult things that we had to do. This kind of fake news, I would say, that one that just try drugs because they may work, and you're absolutely right, maybe they could bring harm to our patients. That's one thing. And the other thing, that the ventilator makes an ICU bed, which is, I completely agree, it's a completely nonsense. Going to that question, I wanted to ask you, how did you increase your ICU capacity in this sense? I will speak a little bit about this later from my experience, but how did you work with teams that were not used to work in intensive care? Is this something that you've done in Brazil? I guess so, but I was wondering whether you can comment a little bit of your strategy to bring teams and to bring competencies at the bedside.
Well, yes, this happened in many hospitals in Brazil, in many public hospitals. For instance, the biggest hospital in São Paulo is Hospital das Clínicas from the State University of São Paulo, and they are now, the whole building are COVID, so they only have COVID patients. So it started much before the beginning of the pandemic in our city. So I believe that what we did, we planned it, because we had you from Europe showing us the relevance of being ready for that. In our hospital, we increased from zero beds devoted to COVID to 83 beds now to COVID. And we only, and some hospitals, this is interesting, in the public network, you had to decide and say to the society or to the state, if you are going to be a COVID exclusive hospital, a majority COVID hospital, a non-COVID hospital. And HC, for instance, is a full COVID hospital. We have both tracks. We are preferable a COVID hospital, and this is also very difficult for the preparedness, because as you know, we have to build the 2 pathways, the COVID pathway and the non-COVID pathway. For us, it was hard, but since from the beginning, the leadership established communication policies. So I think that the most important thing was to have a team committed to this challenge. Everyone, us doctors, nurses, physiotherapists, speech therapists, pharmacists, psychologists, dietitians, social service, all of us, we planned this together, and we are present the whole time, and we're changing the policies every time, looking for improvement. So when we increased for the first all our beds became COVID, and then we start to increase. When we need more people working with us, this teamwork was very attractive. We heard from people saying, I prefer to work here instead of working in another place, because you have a team, we are all devoted to this. And most of all, we work in a safe way. From the very first patient, all the rules to use the protective equipment were the same for everyone. Everyone gonna do the same, and we will care for each other. So if you're not using a mask, somebody gonna point that down. When you are putting the PPE, somebody will say, oh, you're wrong, you should do it like that. So I believe, Mauricio, the most important thing is get ready and get a team involved.
Yeah, I think we can only endorse that. Mervyn, unless you have another question,
thank you. Thank you. No, thank you very much, Maurizio. One of the things, Flavia, that has come up is, having mentioned all the elements, and we recognize there are no therapies out there, that preparation and infrastructural organization is absolutely paramount. What are you using as your standard of care for your patients whom you are admitting to the ICU? So if you get a patient with COVID-19 disease severe enough to be admitted to the ICU, what are you doing?
You mean in terms of medication?
Management.
Yeah.
So respiratory support would be one issue. What about the therapeutics? What are you actually doing?
First, from medication, we always, if the patient is sick, and they are, today, 92% of our beds are occupied with mechanical ventilated patients or patients that are leaving mechanical ventilation. So we do not have here any mild disease. We are just talking about severe patients. So we start giving them oseltamivir. We start to giving them antibiotics, empiric, and we randomize them to one of the trials, always, if it's possible. Okay. So all patients.
One final question. Are you offering them anticoagulant therapy? Are you offering them anticoagulant therapy?
Antiviral? We start...
Anticoagulant.
Anticoagulation.
No. Yeah, only prophylactic heparin for everyone. And we are looking for thrombotic events. We screen them for this proactively for deep venous thrombosis. And in some patients, individualized patients, we use anticoagulants, full heparin. And we are not giving corticosteroids. We are randomizing them to our dexamethasone trial.
Okay.
Thank you.
I think we have to move on, but it's always great to see you, Flavia. And I know it's very tough there now, but I'm sure you'll get better soon. But hang in there.
Hope you are right. It needs to get better.
Good luck.
Bye-bye.
Thank you.
Okay.
Bye-bye.
So, thank you, Flavia and Mervyn. We are going to introduce our next speaker. We are very happy with this series of webinar. We always had a collaboration with the WHO that have been able to tell us what's going on around the world, and also some strategies to try to face COVID-19. So now I would like to introduce Dr. April Ballard. April Ballard is a medical officer for the Infection Prevention and Control Focal Point within the World Health Emergency Program based in Geneva in Switzerland. She holds several degrees, also a Master in Public Health and an MBA. She has 20 years of experience within a wide range of fields, one of which is infectious disease outbreak response. Currently involved with COVID-19 response, prior to that with the Ebola virus disease response in Congo, and in Liberia leading the infection prevention and control and case management for Ebola, Lassa, yellow fever, meningitis, and monkeypox outbreaks. She has also worked in disaster and post-conflict crisis management with Médecins Sans Frontières in Darfur, Sudan, and Colombia. Prior to that, April worked as a clinician in the UK, in South Africa, and Australia. April is also involved in a wide variety of trainings as a strong believer of local capacity building and empowerment in projects in Africa and in South America. She has an implementation research experience within the prevention of mother-to-child transmission programs in highly affected African countries. I think it's an impressive CV, and probably we're looking really forward, everyone, to listening to April talk now, and in the context of low and middle-income countries. Thank you, April.
So thank you so much for the invitation and the opportunity. This is my first time with all of you, so looking forward to this. So today, I was told that there was only supposed to be 10 slides, so I apologize if it's not as comprehensive. I've been listening to some of the other speakers, and I can see you've gone in a lot of depth. So we'll start with this today and see how we go. So for the agenda, I just wanted to really take this opportunity to talk a little bit more about infection prevention and control, the importance of it, to look briefly at the modes of transmission of COVID and their pertinence for IPC, specifically to the PPE use, and then just at the end to summarize some of the guidance of the WHO. So obviously, being ID doctors, you're all very aware of the importance and what IPC is, but I think that it's always good to take a step back and really to think, why we're doing this? And infection prevention and control is important because obviously it protects oneself, the patients, one's family, and the community. It was very interesting to hear before the speaker speaking about healthcare workers and how important it is to work in teams within the hospital, and in particular now with this pandemic and some of the concerns about where the transmission is happening and how it's happening. So this is just once again a reflection of the importance of infection prevention and control. And just to remind us of what that actually means and what it is, this is a scientific approach and practical solution which is designed to prevent harm caused by infections to patients and to health workers. It is grounded in infectious disease, epidemiology, social science, and health system strengthening, and occupies a unique position in the field of patient safety and universal health coverage. I'd also like to take this opportunity really to emphasize that right now we're all in response mode. But really for infection prevention and control to work well, it's important that it's something that is, it's a framework that needs to be put in place. It can be started during an outbreak, but ideally it should be something that should be put in place during peace times. And what does it actually encompass? It encompasses 8 core components. We won't go through all of them, but here you can see the guidance from WHO, which goes into all of these. There's also an implementation manual which links to this. And really it talks about what should be in place for IPC both at a national level and at healthcare facility level. And these include some of the essential components, such as having a program, having an IPC focal person, having guidelines, surveillance, training, monitor and evaluation, and some other points. The point being that if one waits until this to put some of these things in place during an outbreak, what happens in the experiences we have, especially in West Africa, is that the essential health services collapse during that time because everyone repurposes the resources, whether they're financial, operational, or human resources, are repurposed to respond to the outbreak, and many essential health services dropped. And now, as we're seeing, there's been a drop in many critical areas such as immunization. Now, with respect to some of the key elements of IPC strategies that need to be put in place, not just at the programmatic policy level, but also at healthcare facilities. And these were also spoken to earlier, but just to remind ourselves that it is critical, particularly during this time now, to have the screening and triage in place, early recognition, and source control measures. In addition to that, the standard precautions for all patients, which we'll go through very briefly, the additional precautions which are very much spoken to in the context of COVID, and these includes contact, droplets, and airborne precautions. Administrative controls and policies. These include policies around healthcare workers, staff to patient ratio, testing capacity, and then finally environmental and engineering controls. And these are such things as ventilation, which was also spoken to about earlier, and the importance areas such as cleaning of the environment. So just very briefly, what are the standard precautions? Just to remind all of us, there are 8 of these, and these should be done for all. These should be done by all healthcare workers for all patients at all times. And this is irrespective of if one is concerned of any types of infectious diseases or not. And these include performing hand hygiene, the respiratory ethic and hygiene, which we've been hearing about so much during this pandemic, the covering of whenever one is coughing or sneezing, wearing PPE according to risk assessment, which we'll briefly go through, safe injection practices, safe handling, cleaning, disinfection of patient care equipment, cleaning of surfaces and the environment, cleaning and safe handling of soiled linen, and then safe waste management. For the risk assessment, this is critical. This risk assessment is something that most clinicians do automatically, but we're finding right now that during the pandemic, this is becoming more and more important, not only within the healthcare facility, but also when healthcare is being provided in the community settings. It's very much on people's mind with respect to the mode of transmission of COVID. So what is this exactly? This is obviously an evaluation that is done, and it should be done before one has an interaction with the patient or with the client. And what one is doing here is defining what is the risk and the extent of contact of exposure with any bodily fluids, blood, respiratory droplets, and or open skin. And based on this assessment that is done, the type of PPE that should be worn is selected. Just very briefly, everyone is aware of all the different types of PPE there are. And for this group here, I don't think we need to spend much time on it, but in particular that there is a difference between using the respirators and using the mask, whether they're surgical or medical mask. So now we'll just transition and go into more on COVID-specific modes of transmission and some of the IPC measures that should put in place to address that. With the current evidence that we have to date, the main primary modes of transmission of COVID are through respiratory droplets and contacts. There is also airborne transmission, which occurred during aerosol generating procedures. So just to remind all of us, the respiratory droplets are generated when infected person coughs or sneezes. It can also happen when they're talking, and it requires that somebody is close to them when this is happening. The other mode of transmission is through contact. The contacts can either be direct or it can be indirect, and fomites seems to be one of the also important modes of transmission, which basically is when any droplets fall due to gravity on the surfaces or even equipment around, and somebody touches that and doesn't use hand hygiene in between, then they can self-contaminate. With respect to airborne transmission, this is mainly through in settings where aerosol generating procedures happen. This was being spoken about earlier. Many of those different types of procedures, which you're all very aware of, and during this time, aerosols can be generated. And this is particularly important, linked to the type of PPE that is used. So what does one need to do with respect to COVID and the additional precautions? So this is a whole package Nothing stands on its own, in particular, always using the standard precautions. But in addition to that, there needs to be accommodation for isolation. I was hearing earlier as well, the colleague was talking about cohorting patients or having all of hospitals specifically allocated to only managing COVID patients. This approach has many advantages, in particular around not just managing patients, but also the critical supply of PPE, and also with respect to cleaning and the healthcare workers knowing that they're managing specifically COVID patients. Another very simple but important precaution that isn't part of the package is to have the signages up, the postages up. This is done over many different in many different areas of the hospitals and outside of hospitals. It is the PPE that should be worn, having dedicated equipment, doing additional cleaning. This is critical, particularly around areas where there are aerosol generating procedures. Limiting transport really of patients. The patients should be moved to the minimum amount, and critically important is the communication that is happening. And as was spoken about earlier, right now, due to the restrictions of visitors in some places, these are prohibited. The communication channels are critical with the families, and using the videos and being able to communicate through that way has been something that is relatively new during this pandemic. In particular, with respect to ICUs, critical is the adequately ventilated rooms, the universal use of respirators through a shift is something that that can be considered, in particular due to the high number of AGPs that happened, so that the staff don't have to be transferring between using a medical mask and then respirators, having designated teams for caring for patients, restricting or prohibiting visitors, and then also with respect to surgery, there can be considerations on whether should just do the essential surgery or elective surgery can go ahead. This is obviously a decision that should be made at the hospital or at the subnational level, but obviously there are many implications for continuing with surgery with respect to precautions for the healthcare workers, and also the implications for the PPE. And with respect to the type of PPE that should be used, this is something which basically is before, has to do with the assessments that's being done, and due to many requests, WHO did actually produce a guidance which hopefully you're aware of, which is the rational use of PPE. And what this does is that it breaks down the type of PPE that should be used by the health worker, depending on the setting that they're in, and also the activity they're going to use. This is already now almost 2 months old, however, is being updated as we speak. Principles of using PPE, I think this is all well known to everyone. I think the most important point here is that PPE should be changed immediately when it does become contaminated, and it should obviously not be adjusted while taking care of patients. And then just to summarize, we wanted just everyone to be aware of some of the guidances which are being updated at the moment. The healthcare facility one is being updated, taking into consideration some of the issues within the intensive care units and surgery, and also the rational use. And just recently, we came out with the update of the advice on the use of masks. And for this group here, I think the most important point is it builds on recommendations from before. That hasn't changed with respect to the type of PPE that should be used when managing suspect and confirmed cases of COVID. The one thing that has changed within the healthcare facility is that in areas where there is community transmission of COVID, health workers should wear the medical mask continuously throughout their shift in any clinical areas. And the justification for this has been the new emerging evidence on the both the pre and asymptomatic transmission which is happening, which means that there could be patients who are not in the COVID wards who could potentially have COVID. So because of this, through the IPC guideline development group, consensus was come through by all of the experts that this would be something that would be important to try to mitigate some of that transmission, which may be the silent transmission, which may be occurring. The suggestion is to use the medical mask. However, there is very acknowledgement that many health workers prefer to use respirators, and there is language around that in places where there is sufficient availability of respirators and it's a personal preference and the policies accepted, this can be something that the healthcare workers can do. In addition to that, just very briefly, there's also updates on the use of wearing non-medical masks, which are known as fabric masks, for the public in areas where there's community transmission and the control measures cannot be maintained, in particular the safe distancing of minimum of 1 meter. And then just finally to close, just to highlight that there is a WHO Open Academy. This has many courses, and in addition to, there's also the clinical management course, which I'm sure many of you are well aware of. And in addition to having training, it also does do some more practical videos on donning and doffing, as this is something that still is a concern, and in particularly in low income settings, there's a lot of feedback that despite people knowing how to use the PPE, with the additional apprehension around the fear of the transmission, particularly during doffing, this is a high-risk area. So it's very important to continue to do refreshers and around PPE, and to even do some practice sessions before starting a shift. On that note, to say thank you very much.
Thank you very much, April. I think we have time for maybe a couple of quick questions. Mervyn, maybe we start with one. April, you didn't speak too much about PCR swab testing in this strategy. I was wondering whether is that something that in IPC you think it's something that we should not put too much effort because there is no capacity, especially maybe in low and middle income countries, or if it is important, what could we do to support low and middle income countries to have the right capacity to have the better use of these tests?
So you're speaking specifically about doing the nasopharyngeal swabs, correct?
Correct. Mm-hmm.
And doing you mean for diagnostic or for surveillance, or in what context?
I'm not referring. I'm referring mainly for surveillance, for contact tracing. So how to basically to limit the spread of the disease.
Yeah. So it's a good question, and for now, I mean, it's something that has been coming up a lot, in particular with surveillance around, for example, even for healthcare workers within healthcare facilities. And this was something that was also brought actually to the IPC guideline development group, and even within WHO, there's been many discussions. And right now, there is not a consensus on what is the best approach to use. There is some guidance that are coming out now. We're looking at the strategies, and in particular, they're looking at whether it's something that should be done on a regular basis, or it should be something that should be done as a response to people having been exposed. There is no, as I said, there's no consensus, so it's being left down much more right now to policy level. There are pros and cons with doing both types of surveillance, and in some countries they are implementing surveillance of healthcare workers, particularly in areas like in long-term care facilities where there has been super spreader events, and when there has been one case, then they have done active swabbing of the other healthcare workers and even of the residents. But as far as a policy, a blanket policy, this is not something that there is any consensus on at the moment. Over.
Okay, thank you, Mervyn.
Thank you, Maurizio. April, could I ask one question, and it may be a controversial question. Is the WHO guidance on PPE adequate? So we've looked at things. We're seeing increasing numbers of healthcare workers becoming infected. We know that there are significant mortalities within that group globally now, and yet one is persisting with medical masks. There is no advice with respect to head cover. There's no advice with respect to neck cover. There's no advice with respect to shoe cover, all of which have been documented modes of potential transmission. Just a quick answer in terms of things without putting you in any corner at all, just trying to be pragmatic.
Yeah. So I think it's an important question, and there's many elements. I mean, some of the things you're touching on is respect to the modes of transmission. It's also respect to the availability of the PPE, and then what should be used. I mean, we do have in the PPE the guidance that the people should be wearing the shoe cover, a coverage are closed. It doesn't necessarily need to be boots, but they need to basically have a closed shoe. So I think that it's for the healthcare workers. I mean, right now one of the challenges is understanding what is causing the transmission. From some of the data that's out there, particularly early on, and even this is something that we understood from some of the local hospitals in Switzerland, is that a lot of the initial transmission that was happening between the healthcare workers was actually occurring during the times of them having their breaks, when they were having their lunch, or even when they were changing in the changing rooms. So I mean, the whole point around maintaining that physical distance, no matter who you're around, I think is really critical. Having said that, there are definitely situations, and that's why, in particularly for the aerosol generating procedures, there's the recommendation to use respirators, and some of the literature has shown that in the intensive care units that there's a higher concentration of the virus by the PCR, and in particular, one of the interesting things, and maybe I'm sure you read the article, was that it was found on the keyboards, when people were going in between patients, and the contamination happening that way. So it's just to say that it's a complicated area. There are many factors that have to do with it. With respect to the cap and the cover, this would be something that would be more important when one is particularly focusing on contact precautions, and with the Ebola. So with it being mainly a respirator type of transmission, it really becomes important is around the protection of basically the eyes, the nose, and the mouth. But having said all that, there is always, WHO is always looking at the evidence and open to improvement. And the main document around the use of PPE is being updated as we speak. Yeah, thank you.
Well, thank you for that, and that's obviously we all learn, and the interactions are just so important. Certainly, in a resource-limited setting, we've had very creative ideas about how we can use more with less, so to speak. I'd like to thank you so very much for participating, for sharing your expertise with us. It was lovely to have you with us, and we really enjoyed sharing what you could and the elements contained within. So thank you very, very much, April. We're going to move on to the final talk prior to wrapping up. And it gives me absolute pleasure to introduce Professor Maurizio Ciccone. Professor Maurizio Ciccone is full professor of anesthesia and intensive care at the Humanitas Research Hospital and University in Milan in Italy, and is the president-elect of the ESICM, and in fact will begin his mandate as president in October this year. Maurizio is part of the COVID-19 Lombardy ICU network, an emergency task force set up by the Lombardy government and local health authorities to lead the response to the outbreak. He's also co-author of the Critical Care Utilization for the COVID-19 Outbreak in Lombardy, Italy, Early Experience and Forecast During an Emergency Response. And of particular relevance, earlier this month, and I'd like to commend Maurizio on this, and I speak for everyone who's in fact involved in this webinar, everyone in the European Society and beyond. He in fact was awarded the Chevalier of the Order of Merit of the Italian Republic by the Italian President for his instrumental role that he played in the fighting of this coronavirus in Italy, and for alerting the world in February to increase ICU surge capacity and prepare for COVID-19. So Maurizio, I'm going to applaud you on behalf of the global fraternity. Very, very well done. And Maurizio will share with us his personal experience about preparedness and experiences from Italy and how we can prepare our hospitals and ICUs for the COVID-19 pandemic. A real pleasure, Maurizio. Thank you so much.
Thank you, Mervyn, and thank you for your very kind words, but I think I've just been a messenger of a global community in intensive care, starting from my colleagues, researchers, clinical people in Lombardy in Italy, but I would say in Europe. I think that the nice thing about this tragedy that has been COVID-19 is really how unifying this has been for everyone. I also felt a little bit awkward when you asked me to present this webinar that you organized, because I thought I'm also lucky and privileged to work in a setting where I don't really have a problem normally with resources. But speaking with you, it actually made me realize the violence of the outbreak in Lombardy when it started, probably for many of my colleagues and myself, was a very humbling and sobering experience. And I will spend the next 15 minutes telling our story. The story that I will tell, my story, is not a story about machines, it's not a story about beds, it's a story about people. And I like what Flavia Machado was saying, and I think the theme of most people around here, and I guess this is even more relevant, I suspect, for where there are less resources around, is intensive care medicine. It's a lot about people, and with the right competencies and humanity, we can do a lot of things together at the bedside. It was February the 20th this year when a patient on his 30s was admitted to the intensive care unit in Codogno Hospital in Lodi in Lombardy and tested positive for a new coronavirus. That for us in the region was waking up in a nightmare, because up to that moment, we thought that we were able to contact trace every possible case. We thought that we were able to spot patients or contacts coming from China in the previous weeks. Well, this patient was a fit patient. He didn't have any risk factors, or we thought that he didn't have any risk factors. We knew from Chinese data that it was very rare for young, fit people to be in the intensive care. So even if it was just one case, that case made us realize maybe we have a big problem. And indeed, we had a big problem. We changed the risk criteria within a few hours, and suddenly we started to see a lot of positive cases. And it was not just finding the positive cases, it was finding a lot of very sick cases that were requiring ICU admissions. This is the current update in the Italian situation. In terms of deaths, we peaked a few weeks ago. In terms of numbers per day, we still have some deaths, but I would say the situation is much better over the last month that we've come down from the peaks. I just want to show an important table from this, which I think tells a lot of the story, because very often we focus on ICUs, and ICUs are of course very important. I'm an intensive care doctor, so I like to think that intensive care units are important. But a very important message is that I think this battle with coronavirus, until we don't find the vaccine or until we don't find specific treatments that will really cure properly this virus, well, I think we have to contain this virus. What you see in Italy with a case fatality rate of 13.9%, which is very high, you can notice that the case fatality rate becomes very high for the decades of age after the age of 60. And that's an important message. We should try to contain the virus transmission in the community as much as we can, but particularly probably we should take into account concepts like precision public health in order to protect the most vulnerable people. If these people become very sick, not everyone would either benefit or would be able to be saved by an intensive care admission. And therefore, the best strategy is probably to try to prevent the frail part of the society to become infected. And that's the role for everyone, young and old ones. Certainly, after a few days of realizing that we had a problem, probably one of the most important things that happened in our network was that we used the backbone that was an ECMO network set up by Antonio Pesenti and Alberto Zangrillo in the region. And then this became the backbone for starting our ICU network response. And together with Giacomo Grasselli and Antonio Pesenti, after speaking with Joseph Keseshoglu, and I would like to thank Joseph because apart from being a friend and the president, we were speaking a lot during the first few days of the outbreak in Italy. I was on the phone with him pretty much every night, giving him an update. And after a few days, we realized that something big was happening, that no one was really prepared for this, not even looking at the Chinese data that was available. No one had realized that an uncontrolled cluster could bring so many sick patients at once. Joseph and I, we were together in America just the week before the 20th, and we knew that even other colleagues from around the world were looking at the Chinese data, thinking if something like that happened, it could be a big problem, but no one had put contingency plans in action to be ready to surge fast and to contain the virus fast if this was happening. I'm just putting some of the key messages, which I think after nearly 3 months, they still hold as probably important messages. It is about increasing surge, ICU and hospital capacity, but I would argue that the containment in the community and in the hospitals are key issues. And I will go through the other points of these other messages. This was an extrapolation that we did with the Foundation Bruno Kessler, a data science foundation, basically in Italy with Professor Merler. And if you looked at the number of ICU admissions up to the 5th of March, you may erroneously look like this was a linear growth, but actually it was not linear because every day there were a few more patients coming to the intensive care units. And if we would have not controlled this by strong measurements like lockdown that happened during these days, the potential, clearly this is a potential, it's only a mathematical model, it could have been different of course, but the potential could have been for 14,000 admissions by the 20th of March. By putting the lockdown in place, we were able to flatten the curve, and we didn't reach a linear growth, but we were able to significantly slow down the transmission of the virus. Just to give you an idea, and we started from 720 open beds on the 20th of February. That was our capacity for the whole region. In Italy, ICUs are what you would consider level 3 ICUs in most countries. There is a little bit of non-invasive ventilation done in what we call level 2 ICUs, maybe around the world. But the total capacity for respiratory support probably was in the range between 700 and 800 beds. In order to cope with the surge of patients, and we had a peak of ICU admissions on the middle of March of about 151 patients requiring invasive mechanical ventilation, we had to increase hospital beds pretty much everywhere we could. We converted operating rooms, we converted other areas. I have to say, I remember spending some nights with the engineers looking at the total oxygen capacity that could flow in some wards to convert some of those wards to level 2 areas. By the 2nd of April, we peaked with 1,500 occupied COVID ICU beds. We had another 300 beds to cope with all the time-dependent emergency pathology that was in the region, and we included another 2,000 probably level 2 beds. So we went from 720 to 4,000 beds. It was a huge effort, and I will come back to this soon. It was not just about technology. It's about bringing people together that maybe never worked together, that have not been familiar with intensive care for a while, to try to save as many patients as possible. One key element that I think saved some of the hospitals at the very beginning was the containment of the infection and the separation of pathways within the hospital. And that is something that has to occur immediately. It doesn't matter whether you're in a rich resource setting or in a limited resource setting. This is also what April was saying in the previous talk, and I have to say I completely agree. Containment is in the community for the spread of the disease, but when patients are sick, they may have to come to an hospital. And in that hospital, if you don't have an hospital just dedicated to that, you do have to separate the patient flows immediately in order to look at suspected cases, possible cases, and so on. This is something that we did in my hospital. This is a publication that we did a few weeks ago, and this has probably allowed us to protect other COVID-19 patients and also to protect our healthcare workers, especially when you don't have a lot of personal protective equipment, and that was our situation at the very beginning. Creating cohorted areas also allows you to maximize the use of personal protective equipment so that the team that is there will be safe, but can also take care of for as many patients as possible just by the same person. And at the same time, you can use the other part of the team to care for the non-COVID-19 patients. Another key element that I think was incredibly helpful to be able to surge with my team was the fact that from the moment we realized we had to create extra capacity, we thought it's not just finding the empty space, is actually trying to understand how we would work in this new empty space that is clearly not our intensive care unit, how we would work in a way that we've never worked in the previous years. So we had to redo training on personal protective equipment. What we did was bringing a simulation team in situ from the university that worked for 48 hours in a row, and we trained 80 clinicians in what I thought was my priority at that moment. For me, I was not scared about the type of patient that was coming. I knew there was something new, but I know that in intensive care, what we do is providing organ support, and I know that we can do that. The problem is the high volume of patient that comes, and the problem is I did not want to bring risks for my healthcare workers. So we trained a lot on donning and doffing. We know that doffing is probably the most risky part of the procedure because that's when you are tired and when you're removing the equipment. And with all this gear that nobody was used to work on, we trained with teams in doing intubation and proning, and we did some random drills as well. And again, people were then becoming very familiar with this. I was lucky to convince my hospital management also to put a safety officer that was in charge of supervising doffing procedures at the end of the shift. A key, though, is not how you can create extra capacity by finding an empty bed space where you can put a ventilator, is how do we maximize the knowledge and the competencies when we have so many patients to treat. And I have to say what Flavia Machado was saying before, that it's very easy to lose quality in what you do. It's also because we are all working in a stretched environment in ways that were not used before. And I found exactly the same, for instance, that it was very common to see many of the units during the outbreak in different hospitals to see an increase in multi-drug resistance and nosocomial infections. This is because things were really stretched as they were never stretched before. And a very important thing to understand is really that it's not just about using a ventilator, but is how do we bring all those competencies that an intensive care doctor an intensive care nurse, and all the other care professionals acquire over a number of years, how can we do it in a way that we create teams that will be functional to surge and to care for as many patients as possible? This is a guideline that has been published recently and that provides some of this useful information. Useful information, I would say, because if we want to give intensive care to whoever needs and benefit intensive care, and we want to do and try to do what we were doing even before a pandemic, it's necessary to surge. If you do not surge, you may have to select patients in a different way from what you were doing before. We didn't want to do that in Lombardy, even if we were surprised by the violence of the infection. And indeed, if you see the median age of our first 1,600 patients was the first wave that hit us very hardly. It was 63 years of age. 63 years of age means that age was not a risk factor to arrive to the intensive care unit, even if, of course, being frail and maybe having older age and being frail was clearly a risk factor for either being admitted or having a bad outcome after ICU admission. Another important point is I heard many things at the beginning about the fact you should never use non-invasive ventilation on this patient, you should intubate them early. Again, there were a lot of dogmas that were coming out as anecdotes for something that we really we didn't know. We just had some data from China. Everything was new from us. I took an approach with my team saying, if you do not know what we will do what we know, which is basically our common practice and our common approach to patients with respiratory failure. It is true that now we have a new disease, but rather than saying that we will not use non-invasive ventilation, why don't we assess individually these patients and see which ones are the ones that maybe require and can do well with non-invasive ventilation. Not only that, even because the number of resources are scarce, we cannot make the mistake of not discussing and not doing a proper assessment of the goals of care for patients at the very beginning. I do believe that one of the most important part of my team was not just in the intensive care unit, but was a critical care outreach team made by experienced clinicians that were assessing together with the other teams patients after they were arriving in the emergency department. We looked at the data, and this is from our case series. We had about 120 patients that we managed in a month with this outreach team. About 60 patients were deemed to have a ceiling of care, so if they would have been inappropriate for that individual patient to being admitted to intensive care in case of deterioration. So we still provided for some of them a non-invasive ventilation because we thought that that was appropriate. Interestingly, not all of these patients, even if they were old and frail, died, and actually 25% even of patients of care, they were able to leave the hospital. But more importantly, patients in which we thought CPAP is very well tolerated, and these patients are doing well on CPAP. 30 of these patients, pretty much everyone, 29 of these patients left the hospital. And those patients in which you may argue they spend time in CPAP, maybe this delayed the intubation. Well, 76% of these patients that were then admitted to intensive care, they were still able to be discharged home after this pathway. So that's to say that I think for something so overwhelming with this volume of patients, the important thing is to have your team doing simple things well and even doing things in a way that we were doing before COVID-19. In order to be able to work together, I also think it's very important to create a structure and a culture that allows new people that come to the team to feel welcome, but at the same time to do it in a climate of psychological safety. Amy Edmondson, she was one of the opening speakers at an ESICM conference a few years ago. She's a Novartis professor at the business school at Harvard. I had the pleasure to have it as one of my teachers at the research program that I did at the medical school at Harvard. And she talks very eloquently about psychological safety and teams and teaming. I do invite you to watch her videos on YouTube. You can really learn a lot about simple things that can help in order not to be nice to each other only, but to be nice in a way that everyone feels comfortable about raising issues or maybe supervising in a way that you can say, well, this person maybe has never worked and is not really competent on this. I will try to say, why don't you focus on something else? Or why don't I supervise you? Why don't you do a different task today? And at the same time, if I'm coming to the team and I've never worked, I will feel comfortable in saying, maybe what I'm seeing there is not the right thing to do. We should maybe do it in a different way. And one instrument that we used in the peaks of the pandemic, when we had really so many different people working together in shifts, sometimes people that never worked together in a single shift, we decided to create a safety huddle with a very, very simple rule. After everyone is changed and get the handover from their teams, we get together just for a few minutes. We introduce each other so that everyone knows who they are. Don't underestimate this. Everyone is wearing protective gears, masks, just seeing each other's eyes. We have a name written with a pen on our gear. This was something to realize who you are, what's your level of competency, have you worked in this, and then what is the priority for the next 6 hours of work together. This helped a lot to release some of the tension and the anxiety of the team, and I also believe to do a good job and to work in a safer way. This is just some of the pictures of my team, and as you see, people started to smile behind the masks with their eyes. It has been tough. It has been tough, I would say, especially because we had to work without families at the bedside. But it is also been a very unifying moment, and a moment in which we got together as a team, and we got together maybe even more with our patients that were not able to see their families. And especially for the ones that were dying in intensive care, I have to say this was a very touching moment. I'm going to conclude just to show you that a lot of the conversation that we are doing, I do believe that with the right use of resources, we can really achieve a lot. And I think some of these lessons can be extrapolated to also to limited resource settings as well. With the European Commission recently, with Joseph Keseshoglu, we held a couple of webinars, and we are talking exactly about what were the resources that were lacking more during this crisis in Europe. And I really enjoyed today's presentations about colleagues around the world, because it seems to me that both in Europe and in other settings, it is not about the drugs that we're missing. We tried so many drugs in the last few months. We tried so many therapies, but often we were doing it outside of clinical trials. I have the feeling we were left with a lot of questions, but not with a lot of answers. If I have to say, some key messages to me were probably, if I have to prioritize some drugs, I would say we need to prioritize those common drugs that are used, for instance, to sedate a patient on a ventilator and allow you to do sedation holds properly, nutritions, fluids for hemofiltrations, all these things that we use normally for organ support. In terms of other treatments, I think we need to rely on next trials data, on trials that we need to be better prepared to do than during the beginning of the pandemic. Not every country was set up to start immediately doing trials during a pandemic. And I invite you to read and to search for trials like REMAP-CAP, which is a possibility to do in many countries around the world. And when I mention data science, is because without sharing data, it does not need to be machine learning, but without sharing data about what's happening in countries and in around the world, we're not really able to map what's happening and maybe where the resources are most needed. So this is my last slide, and I would say that after working with COVID and speaking with colleagues around the world, I would say that what we have to do in every place is not just focusing on ventilators and the bed spaces. It's how do we increase ICU competencies, and how do we get time to do it, maybe in those places that are out of the first wave in case the second wave hits, or maybe in case there is the next pandemic. And we need to consider probably about moving competencies and resources where they are, rather than just telling single hospital authorities to stockpile personal protective equipment, ventilator, drugs, and then maybe in those places there will be no outbreak, and those healthcare workers could have maybe been deployed to other places where they could have been most needed. We do need to share resources. Probably every system has to work on a network. I like what Arthur Quizera was saying and suggesting. We should probably think about, even in limited resource settings, to work in networks. I can tell you that that works very well also in an environment like a rich resource settings like where I work. And again, working on containment and community, I do believe is one of the key issues that we have to carry on doing to protect patients and to protect our healthcare workers. And with this, I thank you for your attention.
Thank you so very much, Maurizio. I think that was just a brilliant expose from someone who really has insights into this problem. And the many elements that you shared, the principles are not dissimilar in resource-limited settings. If you had to take out a single one-point message from all your experience, all the webinars, all the interactions, all the papers, and the practical hands-on elements, what would you share with individuals who are on this webinar in a single sentence?
I would say people are much more important than technology. Of course, you need a certain amount of technology to do the job that we do. But while you can probably get a ventilator shipped to you in a couple of days, it may take a little bit more time to build those competencies that are needed to use devices in an intensive care settings, or maybe for critically ill patients outside of intensive care. So let's use this precious time, all this learning, all the network that we've done with other people not doing intensive care in the last few months and working with us, not to miss the training and teaching that we've done together, and to work much more without losing time, really, to increase the competencies that make intensive care professionals.
Brilliant. I'm going to hand over to Armand whilst I just load the summary elements that we've been through today. So Armand, it's a privilege to hand over to you, and thank you very much once again.
Thank you. So we are getting close to the end of this wonderful afternoon. It's now the time to let Mervyn Mayer give us some summary to wrap up the important messages that were given by the different presenters this afternoon. So it's a great privilege for me to let Mervyn give us this summary.
Thank you so very much, Armand. I think if we run through the elements of the afternoon, this wonderful webinar, I'd like to just go back a step or two and just to allow people to take in what has happened and what ESICM have put into all of this over so many weeks. So several weeks back, it started as a marathon webinar that was put out. Then there was a half marathon webinar. There have been many others. And in fact, this is the first broad webinar focusing specifically on low middle income class countries. And if we look at the elements of marathon, half marathon, I'd love to believe that this was a 3-hour power fun run. So having said that, I think, those were the elements, and I hope everyone has had fun and taken out stuff that is hugely helpful in the context. We had an initial introduction by Massimo, who gave us an overview, effectively, of COVID-19, some of the important elements pertaining to it, and also gave people an idea of the ALIVE initiative and project, which really is an absolutely remarkable initiative, looking at both a very pragmatic theoretical component together with clinical bedside teaching done essentially over a 2.5-day period that has the potential to change sepsis care all over the world. So this is an exciting initiative. If it is rolled out appropriately, and the 3 rollouts that have occurred already have been absolutely remarkable. It's the only way to describe them, and it could become the benchmark on which we in fact level elements in resource-limited settings. We then moved into my co-chairperson at the present moment and moderator, Armand, who gave an excellent talk on what we currently know about the disease, set the scene about the pathophysiology, discussed the patterns of organ dysfunction and the relevances thereof, and overviewed the causes of death, which were very important to understand. And then we moved into an absolutely lovely talk from Martin Dunser, looking at the clinical elements that were important in identifying patients, together with the laboratory features, imaging elements, what we should be doing specifically for testing, and how we can, in fact, in a very simplistic way, look at differential diagnoses, and in resource-limited settings, exclude certain issues that don't often fit specifically into this context. Then there was a very pragmatic talk on respiratory support in low-middle income countries, and we need to go back and just bear in mind some of the elements that 87% of the world's population in fact live in resource-limited settings, and around about 85% of all sepsis globally occurs within these settings. There are very weak infrastructural elements in many resource-limited settings, which means that many of the important lessons that we've learned with respect to managing patients with this pandemic may not necessarily be evident and available in resource-limited settings. And so the focus on oxygen and early intervention is enormously relevant. Arthur Kwazira touched on awake proning, and I shared some of our own experience. If a patient is in fact on a non-invasive device, you can get them to stand up or sit in a chair. It helps enormously. And in terms of mechanical ventilators, it was shared that the reality is that in many institutions and in many resource-limited settings, this is in fact something that may not be feasible. But having shared with some of the issues that have been learned from resource-richer settings, the basic principles of mechanical ventilations should be followed. Flavia then took us through the therapeutic principles and other considerations, including, very importantly, the humanizing elements. We are looking at physical issues and humanizing issues, and I'd like to just remind individuals about what the definition of health is. And the definition of health is a total state of physical, mental, and social well-being. And that encompasses everything we've chatted about today, including the pressure on teams, including how we evaluate our patients, how we manage them, and how we in fact look after ourselves, and how those patients who leave following COVID ICU care should not be forgotten as well. She touched very pragmatically on fluids, anticoagulants and antiviral therapy, indicating there is no formalized therapy at present, but that therapies are currently undergoing evaluations and should be, patients should be enrolled in trials. And she looked briefly at complications, very importantly mentioning issues like nosocomial infection, which means that we have to go back and provide adequate attention to detail in these patients. We had an excellent talk on infection prevention control measures by April Balla from the WHO, who looked at routes of transmission, explained them, and we touched on personal protective equipment as well as modes of transmission in the community, and was very, very open to the issues of addressing adequate PPE, which is a very important issue, particularly where limitations may in fact occur in resource-limited settings. And then we finished off with a really outstanding talk from Maurizio, sharing his lessons from Italy, which were very, very important, very pragmatic, very appropriate for all of us who are now having to deal with the issues as things, in fact, settle down a little in other areas of the world. And there was emphasis on preparation, on maintaining a degree of pragmatism, on being flexible in terms of the lessons that we learn, in terms of adequate communication, and in terms of appropriate networking and in being inclusive in issues. And I guess if we take out things from there, one of the important elements that we can share with everyone is that the good old saying that experience is the best teacher is very, very relevant, and that the best form of interacting with people is to communicate adequately with them. So what are the elements that we need to wrap up with? And first of all, there needs to be gracious and very humble thanks. Number one, to all the excellent speakers today, to the ESICM exec for their fabulous support, and in fact for interacting and communicating and initiating this very webinar. Thank you so very much. To the superb administrative staff behind the scenes, Cindy, Estelle, the audio-visual personnel, to the Alive contributors for all their work that they've done over the many months that this program, in fact, has been going. Too many to mention in name, but a massive thank you to everyone, including the Academy. And to all our wonderful colleagues around the world who've joined this, who really are the champions of care. Those are the people we really need to thank enormously. To my good friend and colleague, Martin, for all the many hours of communication and the ongoing enthusiasm, just a massive thank you. And to everyone who's contributed to this fund, a huge thank you. And then a couple of lessons that I'd like to sort of share, if I may, and very humbly as well. Being poor and working in a resource-poor environment doesn't mean to say we offer poor care or that poor care is applicable. In fact, very simple elements can make a massive, massive difference. We can intervene appropriately together with creativity and innovation, and as a consequence, in fact, offer sound practice with very good quality care, even in very constrained environments. And we should all endeavor to do that. It should be our aim, it should be our target, and we must always aspire for excellence. We've got to have passion, preparation, and that's got to be put into a channel with purpose. And then finally, I want to share that it is so important for all of us who work in any setting, including the intensive care setting, with critically ill patients, that it is critical to care. And I want to take you through a picture that moved me enormously. And this is of an individual with COVID-19 disease, in which the option of mechanical ventilation was not present. In other words, there was no option of mechanical ventilation. And this patient was on a progressively downhill trajectory, but it indicated one entity. He wanted to see another sunrise. And so the human elements that we've spoken about should never be forgotten in the context of the care that we deliver. And so this individual was taken out to share a sunrise. And in fact, whilst the sun was probably setting on his own life. If we move to the Alive initiative and project, and as someone who really enjoys the use of words and poetic associations, we need to strive with Alive to ensure that patients in low middle income class countries, resource limited settings, thrive and survive. And there's no question of doubt, Alive is very much alive. So I implore you to go out and do it with passion and drive. And if you look at the pictures below and some of the really significant resource limited settings where in fact things have occurred, and the enthusiasm and the passion, this is an amazing issue. And I'm very, very grateful for the opportunity just to be part of it. I've grown up in a country where we've known resource limitation. In fact, in my own country, 55% of our 60 million people live on less than 1.5 euro per day. And we were taught very many excellent lessons by a wonderful human being when we go back to the human elements, and that was Nelson Mandela, who overcame many, many obstacles in the face of significant adversity. And I've often quoted him quite extensively, but today I want to share a quotation that I think is particularly apt for what we have just spent the last 3 hours doing. And he had the following to say, and in fact, if we look at some of the terms there, very apt to what we were discussing in terms of some of our own topics today with respect to hands, and he wasn't focusing specifically on infection prevention control. But I think the message is a profound one. It is in your hands to make a difference. And the sentence is finished as follows: to make this world a better place for all who live in it. And that is what we need to be striving for. I have the opportunity of working in a resource limited setting. Sometimes we have some issues that are available in higher income settings, and sometimes we don't. but we definitively go out and we try and make that difference. And when we're talking about that difference, it's to try and offer life to people, because that's what it's about in the most appropriate setting. And next to me in the hospital that I work in is a school. And every morning when I arrive at the hospital, I pass that school. And every morning, late in the morning, in other words, late at night, or in the latter evening when I leave the hospital, I pass that school. And that school's been closed because of the COVID-19 epidemic. But the choir in that school did very much what I think could almost become a theme song for Alive and for people all over the world, and particularly resource-limited settings. And it gives me warmth and passion and enthusiasm and the knowledge to know that where I practice and where all of you do as champions of care, there is something that makes this all worthwhile. So I'd like to finish off by sharing with you something that these school children in Africa put together about life. And it's about rejoicing in the joy of life. Could we have the clip, please?
A secret chord that David played and it pleased the Lord, but you don't really care for music, do ya? Well, it goes like this: the fourth, the fifth, the minor fall and the major lift, the baffled king composing hallelujah, hallelujah.
As that plays out, I'd like to bid farewell and offer my gracious and humble thanks once again, and send warmth and friendship from a resource limited setting and to everyone around the globe, to the amazing and valued colleagues all around the world. And thank you for the opportunity for being part of this. I'd like to hand over to Joseph to close.
Thank you, Mervyn. Joseph is about to be on stage, so thank you, Mervyn. Thank you, Armand. And Mervyn, if you wanted to make it difficult to see, probably you choose the right close. Maybe just realize how the fact that even a moment of distance not mean they really have social thing, and all webinars this time out we're using is together. The wonderful example is the song of the school, and really trying to do the same with our intensive care medicine community work. It just makes me proud to be this, and I have to say I would like to Joseph, our president, and thanking him for his leadership during these times, and to pass him the words to closing.
Thank you very much, Maurizio. I think after Mervyn's words and the film, there are not much things to say, but I would like to indicate that what we have heard this afternoon has been immensely thought-provoking and insightful. I would like to send a strong message of support to all intensive care professionals, particularly those working in those countries where the battle against COVID-19 is still being fought. I know that you will find the strength and courage and unified approach to win. And on behalf of our intensive care community, we stand with you. ESICM has many excellent free access resources at your disposal on the COVID-19 resource page on its website, which are continually being updated. And we will continue to provide regular one-hour webinars and to endorse collective research studies and surveys to help this cause. I would like to thank all the presenters, moderators, guest speakers, and social media team for their time and for sharing their valuable knowledge and experience with us today. I wish to thank the audience for engaging with us and for the many questions and comments. I hope that you have found this a valuable use of your time and are ready to continue your work with extra confidence and assurance. Finally, I want to acknowledge the companies who have supported today's webinar and helped us to provide this important dialogue and learning for our global intensive care community. Thank you all, and goodbye.
Bye-bye.
I'm a critical care nurse. I'm proud to work together with other professions as a multidisciplinary team to fight COVID-19. Together, we are intensive care.
I am an anesthesiologist and I'm proud to be an intensivist. Together, we are fighting COVID-19. Together, we are intensive care medicine.
I am a critical care nurse and perfusionist. I am proud to work in an intensive care unit. We are working together to fight COVID-19, and together, we are intensive care medicine.
I am an internist and I am proud to be an intensivist. We intensivists are working together to fight COVID-19. Together, we are intensive care medicine.